on Zoom, and it's gonna make it hard for folks to hear us. So, everyone, if you could please make sure that you avoid side conversations. I've got sticky notes, if you want to pass notes to each other, that's fine. And if you could all kind of use more of your outdoor voices, with the exception of Anna, who lost her voice last night at the Green Day concert. Anna's gonna just write me sticky notes and I'll speak for them. But if everyone in the room can use their outdoor voices today, that would be great. Folks on Zoom, it's the usual drill. If you are a member of the CRIS Committee, please have your video cameras on if that is available to you, and your mics muted unless you're going to speak. Please use your hand function if you'd like to speak. And Becky Jones is going to help you track who's got their hands up. On what? And also, folks on Zoom, if you have a question or a comment you'd like to make via chat, you can send it to me, Jamie Strauss-Clark. For our community members and guests, it's also the same drill as always. Please keep your video cameras off and your mics muted. The exception will be at the end of the meeting when we do public comment period. I believe we have one person signed up for public comment today. And if you can send a chat to Christine Milana if you would like to make a public comment, and she will add you to the list. I think that might be it for and this for folks in the room, quick housekeeping. There's coffee and tea over here. We'll be bringing in lunch at 12:15, and that will be in the back of the room. And if you need the restrooms, they're out the door rather, and to the right down the hall, the restrooms. You also may see some folks you don't recognize. This is our fantastic panel discussion for today. We're going to be focusing on crisis response for people with intellectual or developmental disabilities. And so our panelists are just coming in. We also are going to have a few on Zoom. So please make them feel welcome as well. We're going to get through a little bit of business and then we'll start the panel. Well, you could announce or Christine, I think, did you announce the slides a couple? I think we can select them. Oh, good, thank you. A couple more reminders. There's Wi-Fi available for attendees. There's a little tag on your table. Use the account that says DoubleTree meeting. That's how you can get on Wi-Fi. There's also scholarships on your table. Yeah. We have, I know there's another COVID spike. We have masks here for anyone who would like to use them. I have a mask, but I'm going to keep it off while I'm speaking just so you can hear me. And there's also lots of hand sanitizer. So everybody take care of your health today. And then if you parked today at the DoubleTree, Jared over here has vouchers. You can come pick one up. So all you do when you're leaving is stick in your original ticket and then follow it up with the voucher, and it should be zero cost for your parking. I think that's it for logistics. So please advance the slide. You can skip these. Everybody's not. Awesome. All right. So today's objective. So we're going to, as always, ground our work in the personal stories and experiences of people who've encountered the crisis response system. And today actually we're going to have a special treat because today is when we're going to hear all of the outcomes from the lived experience stories project. So that's going to be a really important part of the meeting. We're going to hear some updates from state agencies and subcommittees relevant to this committee. And then, as I said, we're going to learn about the unique needs of people with intellectual and developmental or developmental disabilities who encounter the crisis response system from our expert panel. As I mentioned, you'll hear some key insights from the Lived Experience Stories Project. And then we're going to spend the latter half of the meeting focusing on refining our recommendations that will go into the final CRIS Committee report at the end of the year. And then we'll confirm actions, next steps, and hear public comments. So if you could advance the slide, then we'll just get the timing up there for everybody. All right. The sound on Zoom is not great. It's a bit garbled. Okay, so I think it sounds like people can still maybe hear a little bit of background. So everyone in here is pretty quiet. So we'll do our best to enunciate. Sorry about that, folks on Zoom. All right, so let's get started.
Yeah, they texted and said that it's when you turn to face this way that it's hard for people on Zoom to hear you.
I will write that. Okay.
And they are hearing lots of side noise for some reason. So We'll try,
All right.
see if this helps.
All right, folks on Zoom, we'll do our very best. I hope you give us some grace. This technology has some benefits and challenges. But I will let you know, folks in the room are actually being really careful to speak or move around too much. So we'll keep doing our best there. All right, so after we get through this welcome and introductions, we've got some agency updates for you. And then from 11 a.m. to 12:15 is when we're going to be hearing from our expert panel. And there will be an opportunity toward the end of that to ask your questions. That we have some pre-written ones, as you know, for the expert panel. And then we'll have some questions from you at the end of that. Then we'll take a lunch break until 1 o'clock. And that's when we're going to come back here and hear about the outcomes of the Lived Experience Stories project from Vikasha and Kristen. And there'll be some opportunities to ask them questions and share your feedback as well. We'll take another break at 2 o'clock. And then starting at 2:10, we'll get back together and work on refining our recommendations for the final CRIS report. We'll move into action items and next steps about 3:35, and then do our public comment at the end of the day. So that's the day. We'll adjourn at 4 o'clock. That's the plan for the day. Before we get started, I do want to introduce a couple of new CRIS committee members. So first we have Blaze Gedry, who's a police lieutenant with the city of Vancouver. So welcome, Blaze.
Thank you.
Thanks for being here. And then on Zoom today, I think we have Chloe Marino.
Hello.
Welcome, Chloe. Sorry, I'm getting my notes back here. Bear with me just a second. So Chloe Marino is with the Treatment Facilities Program, Disability Rights Washington. So it's representing folks with disabilities on the CRIS committee. And we also have Tori Gilbert with Behavioral Health at Molina Healthcare of Washington. Welcome, Tori. Gotta stop turning my head back there. That's just a reflex. All right, let's get started then. So I'm going to move into agency updates. You should have received a newsletter. I think we have some updates on the regional crisis lines 988 policy coming in. And also HCA is going to give you an update on the bed registry and what to expect in the future. And I heard, Jane, you also have an OIC update real quick. Okay. All right, so let's get through these because we want to make sure we start our panel discussion right at 11 a.m. And then finally, there's going to be an update on the next steps for engaging folks with lived experience. So, Tisha, Michelle, who wants to start?
We let Jane start.
Ooh, yeah, Jane, you want to get it on?
Okay, morning everybody. So really quick, just a couple of OICs in the process of doing a bunch of rulemaking. And some of you might remember that back in 2022, the legislature passed a bill that required commercial health plans to cover behavioral health crisis services, just like an emergency visit. And while there was a working that got together to develop a best practice recommendation about how health insurers should contract with behavioral health agencies, what we had been hearing from some of the BHASOs and behavioral health agencies is that carriers didn't seem to be, let's say, Jan's nodding her head, implementing the consensus recommendations. And so we are working on the rule now to integrate that language into our rule, which means it won't be a best practice recommendation, it will be a law. So we anticipate that that rule will be adopted by the end of this year. And OIC has sort of a rulemaking page. I can send Jamie or folks the link to it so that you can follow that rulemaking. And then the other heads up is some people might remember that back in 2023, the legislature passed a bill requiring stabilization of medication for people with serious mental illness who were stable on a med. And that bill had a delayed effective date of January 1, 2025. So heads up, we're integrating that into our rules and that will be effective as of January of next year. So,
Thank you, Jane. And I realized I missed one very important introduction. I think we introduced Jennifer. I can't remember if we introduced you at our last CRIS committee meeting, but we should make sure for this is Jennifer Chancellor in real life, our new 988 coordinator for the governor's office. So welcome. Thanks for being here.
Thank you.
So Tisha and Michelle, you want to jump in with some of your updates?
Absolutely.
quick sound check, can people joining virtually hear us okay?
They have actually texted and asked people around the table to speak loudly and enunciate more clearly would be helpful.
Thank you.
Thanks, Michael.
Good morning, everyone. So great to see you in person and also virtually. I'm Tisha Kirschbaum. I'm the Director of the Division of Behavioral Health and Recovery within the Healthcare Authority. Really excited to share the updates around the regional crisis lines and the 988 joint policy statement that was recently released. So I'm hoping that most people have seen that information, and if you haven't, just a quick overview of what it states. It's really looking at the future state of how the role of 988 and also the role of the regional crisis lines and regional collaboration that's needed. So the quick summary of the future vision or the joint policy statement is 988 will be the public facing number for people to call. So as we're marketing, as we want the public to interact, we want them to call 988. For our regional crisis lines, the service and the work that they do are also critically important. And we are really pivoting their focus to continue to really be the professional line for people who are the professionals working in the field, who are doing an in-person response, that are helping the individuals who are in crisis on the ground level, for them to be able to have a way to help coordinate services, and also at the regional level to be able to coordinate the deployment of what services are needed if an in-person response is needed. I really hope if you haven't had the opportunity yet to read the policy statement that you take a chance to look at that. I think also just to know that it really kind of states the vision, but it certainly doesn't have all of the future details worked out yet. And we're committed to doing a pretty robust stakeholdering process. And my guess is that most of you will be engaged in as we move forward to kind of work out all the nitty-gritty details about how to make this transition as smooth as possible.
Thanks, Tisha. I want to pause there really quick. Do any CRIS committee members have questions for Tisha about that rule or that new policy?
So basically, we also just ensure that for all the clients that we have, we should be given them the 90-day stay of the crisis line. So we change it. We have all our cars have the crisis line in the back, so everybody 90 days.
So it's not something that's happening immediately, but we do want to pivot to the idea that for the public, the number that they call for crisis services is the 988.
And for folks on Zoom, Claudia just asked a question, just to reconfirm that what we mean is for anyone in a crisis to call 988. Tisha said that is the intent, and we're implementing it, but it's not right at this moment. Okay, great.
Thank you.
Other questions? Yes, Adam.
So the way I read it also, regional crisis lines are kind of being the dispatch kind of. For dispatch for DCRs and other
Yep.
teams like that. So I would assume that for 911, we're probably gonna be connecting a lot more with the regional crisis lines when we need.
If you're
To get
needing
the
that
resources
in-person
out there.
Yep, it's all
Okay.
about what's needed on that in-person response, on the local level, the regional expertise.
Okay.
Any other questions from Chris?
I would say though, on that piece, if you're handing a caller off, you're
Yes.
gonna start.
Well, that's
handing
what-
the
yeah.
caller
No,
off.
yeah, if it's a,
We're already doing 988, and they'll do the coordination and the handoff if in-person response is needed. But if it's like a provider to provider type of relationship, so like a 911 call center needs to talk to the response teams and the kind of coordination, they would, call the back door,
yeah, because we get a lot of calls where, maybe the police out in the field say, hey, we need the DCR, we need this. And so those will just go straight to the RCL. So we'll have to include those all in the procedures. Okay.
Other questions from Christine?
And if I could just throw out, this is Tisha again, I think just these details that the conversation that even just started organically right now in this room, that is some of those questions that need to get worked out in the future, and we're hoping, well, first of all, I want to say thank you for raising them. We need to raise all of these questions to make sure we have thoughtful and it's well worked out, and that is part of kind of in the future with the stakeholders that we do. How do we get to these types of questions and work through the protocols and the procedures so that people are well served? So thank you, folks, for asking the question. That is really what we're looking for.
Thanks, Tisha. Okay, and then, do you also have an update for folks on bed registry?
Absolutely. So the bed registry work, I had in my notes that Maddie Cope was going to be available to, or she's not.
Maddie Cope, are you on Zoom with us?
I am. Can everyone hear me?
Yes, you sound great.
Oh, perfect. Okay, awesome. So yes, a brief update on the bed registry and referral project. So if we want to go to the next slide really quick, this is kind of the series of stuff I'm going to talk about really quick. I'm going to give a review on what the project is about, some of the work that we've done to date, a few of the key findings that we've done, but I'm going to spend the most time on the next steps. So an overview of the project is basically HCA applied for a TTI grant from NASHPID and received that money for a couple of grants. And we've spent that money in order to basically scan the environment as it exists now, understand the challenges, successes, risks of that exist currently with various interested parties. So I want to say a special thank you to those in this group that participated in our listening sessions that we hosted with our vendor Barry Dunn. Thank you so much for the information that you provided us. That information, as I'll get in more detail into our next steps, is going to directly impact the future of this project and 90 Data as a whole. So kind of the bleeding into the work that we've done to date here, we have done a lot of listening sessions, and those are complete as of August. We've done many web surveys. Those have been completed as of July. And all the information that was collected as a result of that has been put together in a deliverable by our vendor called a needs assessment. And some of our key findings that we put together in that needs assessment include things like we want to include a filtering function for various things that we want to filter out, including insurance coverage, types of beds, any exclusionary criteria that any facility has, and many other filtering things. Automatic updating to limit provider burden as well as administrative burden, manual labor on the part of our providers, and ensure the reliability of the information that's delivered. We want to support rural and other providers that have limited access to internet and or limited EHR structure, excuse me. And those are just a couple of the key findings that we have. There are so many, and that needs assessment. If we want to go to the next slide, which are next steps here, that needs assessment is going to be delivered at in October. So this is going to be a compilation. It's a really long document, but it's a compilation of all the challenges, needs, risks, desires, anything else that were collected during this whole process. And it also includes some recommendations from our vendor, Barry Dunn, as a result of that feedback that HCA will take into consideration when we continue to develop this project. And that's going to include, anything from the requirements that we're going to put into the request for proposals. So that's going to impact how we ask our vendor to put together the functionality of whatever system we put together in the future. And that's going to directly impact what functionality is available or not available in the future system. So I have a lot of other dates here, but I know I'm on a limited time here. So this information is going to be available to you as a result of these slides. I'm also happy to answer any questions that you have, but I think that's all for me. Yeah.
Thank you, Maddie. This is Tisha again. Just a quick high level couple of notes. The bed registry is important because it really connects to someplace to go. There's going to be times when a person needs someplace to go, and right now, as I'm sure everyone is aware, for that someplace to go is really labor intensive, where individuals are calling around the different facilities to find out what's available. Or sometimes you might have a person who's the family member or the help seeker themselves trying to access this information. So what we're attempting to do is create a solution where there's more of a universal bed registry that to make it easier for when you're looking for someplace to go for that's easier for the entire system.
And this will include all beds, mental health and SUV, or you talking about mental health?
Well, so it's going to include that's some of the things that we're looking into. I would say it'd be very difficult to not include substance use disorder because, a person's crisis is not always connected to only mental health. We need to make sure that we're looking at the whole person.
Okay, and again, just to make sure folks on Zoom heard the question, so Claudia asked, this is for all types of, including substance use disorder, and Tisha answered affirmative. Kashi?
I have the same question about pediatrics, are peds beds in the scope of this project?
So again, what I'm gonna say is, I think that's part of what you're gonna see in the findings, is it's going to say like, what needs to be in scope, how do we, if we're gonna build a bed registry that has absolutely everything in scope, what would that look like? I can't imagine that we could have a registry that wouldn't have peds beds in it, because then we're saying that, you know, like those, like, yes, it needs to include the whole continuum, and how do we, if we're gonna build that, what will it take? Yeah, so that is there scoping that is needed? But that's part of what we're looking at is, and part of that environmental scan that Maddie mentioned, that like, how does it work now? And if we were to transition to what are the types of beds that people need when they're in crisis, what does that all look like? And then how would we build a system to respond to that?
Other questions? Michelle?
So one of the challenges, thank you for the update, this is really exciting. One of the challenges is adoption of whatever the solution is, and making sure that the providers prioritize it, but also have the resources to keep it up to date. I think that's going 2 steps down the road. That's probably the bigger challenge versus finding the tool. Will the HCA be kind of leading the effort around adoption as well?
Probably, I'm assuming so. I think that's, like you said, that's a couple of steps down the road. I can tell you that that has been a really strong message that we have heard as we've done the stakeholdering process here in Washington and other states across the country as they've attempted to build a bed registry. Like, it only works if it's updated. And so how do you make it user-friendly enough for the providers to be willing to update it on, you know, a fast enough timeframe that it's up to date? And that actually has been a consistent theme across the country as different states attempt to implement bed registries.
Thank you.
If I could just make a comment, I think one of the things we're trying to do in behavioral health generally is to make linkages between all the different committees that are doing behavioral health work. And we actually, there's a number of us who are on the behavioral health Joint Legislative Executive Committee, which just met yesterday. Anna's on, Jane, Tisha, and so we were just talking about, in terms of a global perspective on part of what that group is tasked with doing is doing a bed inventory and sort of a future-looking bed. And so we talked a lot about what's the work going on in 988, what's the universe that exists if we're going to do something more systemically. So I think more work to come from that group as well, but I just wanted to make sure this group, you know, again, trying to make the linkages between all different behavioral health committees and some of the work that's going on.
And I see Maddie has her hand up. So Maddie, why don't you go ahead and Betsy has a kind of way we can close this particular discussion out. Maddie?
Thank you. Yeah, I missed who asked the question about, you know, making sure that the adoption of the new standards and everything is upheld. We did some of our interested parties included providers and EHR users of various types. And we also had various conversations around how do we, you know, incentivize or require that within the best, you know, in the best way so that everyone's on board and happy about the adoption and that it's something that everyone is willing and able to achieve.
Maddie, you froze up a little bit in the last part. You just said willing and able, and we missed the last bit. What you said.
Willing and able to achieve. Yeah, sorry about that.
I think we got it. All right, and then Betsy Jones, you were around.
Yes, so more information. See in the newsletter, so first members take a look at the newsletter, it's jam-packed with information. And we are scheduling a process and subject about the RCL policy. So more to come, and we'll loop back around to you all. That's it.
All right. We have, and we'll get started. We'll let you know, folks on Zoom, we're working on getting some additional mics set up to make it a little bit easier for you here. Although I want probably that to wait until after the panel, so we go about the expert panels to disrupt their presentation.
I'm afraid that people have to hear that.
I'm gonna see if I can move the. All right, I'll tell you what, here's what we're gonna do. I'm gonna make it quick. Here's what we're gonna do. Samuel, how long will that take to set up?
Probably about a minute.
maybe less.
Okay, because I don't want to disrupt, we're gonna have a presentation, I don't want to disrupt that, is this maybe if we move the owl a little bit closer to this back section for now, and we can set that up at noon?
The owl hasn't moved at all, so I'm a little unsure. Like it has a little face, I presume it's supposed to move.
Okay.
Yeah, it's at 3:60.
No, I'll look at the dog.
It'll be okay. And the way it's going, like.
Oh.
I can't really move it any further.
That's the plan, but yeah, like it's. Back out.
The main feed has cut out, or is that just me?
They're rearranging things so that it's more workable.
Okay, all right, folks, we're getting back online here. All right, so folks on Zoom, please bear with us. We're trying to get some more mics and speakers out so that we can hear a little better. I do have our expert panel and I want to get started right at 11 with them because they've all come a long way to be with us. And have very busy schedules. So we're going to go ahead and start that. Samuel is going to do his best to make sure that it's not too noisy back there and disruptive. And then I know we have one more update to share on the plans for our continuing engagement with lived experience. Let's go ahead and do that at the end of the meeting today so we can get started with our panel on time. All right, and David, so you know, Jermaine and Mikkel are a family that they are going to be participating on via Zoom today. So, Chloe, if you could find Jermaine, I think he's in there. You could, there you go. Hi, Jermaine and Mikkel.
Hello.
Hello, thanks for being with us. All right, so I think we're ready.
Can we have them big instead of the slide?
Yes, let's take down the slide. Thank you. So Chloe, yeah, they're perfect. Now, okay, wonderful. Now we can see. And then if you could unpin if you could unpin Abby or spotlight Abby so that we can see only people with their cameras, just the both cameras. Perfect. All right, I think we're in business. So David, do you want to kick it off?
I don't know, do you want me to do the intro piece or no?
Well, here, so first what I'll say is, and I've shared this with everyone, as folks know, we have been doing these expert panels to help this CRIS committee learn more about the unique needs of specific populations who are encountering our crisis response system. So we've done substance use disorder, rural and agricultural populations, youth, and tribes. And today we are focusing on people with intellectual and or developmental disabilities. And we have this outstanding panel of experts and lived experts who are joining us to see. I think David's going to start with a level setting presentation, and then we're going to get into our questions of our panel. So now I'm going to hand it over to you.
Okay, so we don't need to do any introductions. You all have a handout, right? So
yes, everyone should have gotten their panelist bios. But panelists, when you speak today, if you don't mind just reminding everybody who you are, that would be fantastic.
on the handout, I'm David O'Neill. Please read that right there. So we're gonna do, they talked about doing a little bit of level setting just to identify the population we're talking with. When Jamie talked about all the other subgroups that you've talked about, the interesting thing about people with intellectual and developmental disabilities, they cross all of those, right? They live in rural things, believe it or not, they might use substances, you know, all these other factors just are, this is a population that crosses all, walks of life. And it's, I think, you know, when you look at all the different kinds of disabilities, it's so life impacting when you have an intellectual and developmental disability. Now, we have DDA here who can correct this, but it used to be we looked at intellectual and developmental disability from an IQ perspective, where you looked at the IQ of 70, and that was 2 standard deviations below the mean, and that meant that, you know, that this was an intellectual disability based on a test score. Well, we found those numbers can be misleading. We found that people with IQs of 70 or below might be doing just fine, and those with IQs that are higher than that might not be doing so well. So I moved to more of an adaptive skill deficit as a critical component to eligibility for the Developmental Disabilities Administration. So that piece, I think it plays into some of the etiology of intellectual and developmental disabilities. There's, I don't know, at last count that I saw from some scientific journals, there was something like 350 different causes of intellectual and developmental disabilities. And I don't think that even scratches the surface. I think there's a lot of other things that are continually being discovered. I mean, you have an autism rate right now of 1 in 56 that is just, since the time I started, that's a significant increase in the amount of individuals. So again, adaptive skills, which is again how people depend on others, how, you know, I think the next slide kind of addresses it a little bit more. So put the next one, please. Executive functioning. So this is kind of an inherent piece of someone who has intellectual and developmental disabilities. And this is actually, I would say, this is of all people, right? All of us have executive functioning areas. This is just a big umbrella term. That's a collection of related functions in your brain that usually is operated by your frontal lobe. So all of these things, people that know me, the organization of materials is an area that I struggle with. I heavily depend on Post-its all over my desk. Not the best organization of materials. I'm a piler, not a filer. You know, there's all these things. I have a few deficits, but I'm able to adapt, overcome a lot of those deficits due to my cognitive ability, right? So someone who has neurocognitive deficits is going to struggle a lot more with those. I have emotion regulation highlighted there because that in and of itself isn't necessarily an executive functioning deficit area, but it's an area that is impacted. And it starts a crazy cycle where if you aren't able to, you know, cognitively flex and move from task to task, then you might become emotionally distressed, which then causes you to have a greater difficulty in having cognitive flexibility, which then causes you to get more emotionally. And this is not, not very different for many of us who are put in stressful circumstances. But this is a major component of intellectual and developmental disabilities that I think plays into what we see in the world of crisis. Next slide, please. This is an individual who we work with. Was referred to us for the wonderful presenting problem of aggression. So aggression is not very diagnostically specific. I don't know how many of you can diagnose somebody if they came to you and said, I have back pain or I have a fever. These are not really very specific, right? So here is a person who presents aggression with different kinds of influencing factors. So you can see all the variety of things that happen. You know, you might have, if you have constipation, you might get aggression. If you are depressed, you might, if you're bored, you might get. So all of these factors that play into the presentation of what we're seeing. And when you're talking about crisis, we're often talking about something that has presented itself, right? So when we see these kind of things, if we don't dig a little deeper, we're probably not. There's a guy who's a little bit smarter than me, Albert Einstein. I don't know if you've heard of him, but he said, if I had an hour to solve a problem, I'd spend 55 minutes on the problem and 5 minutes on the solution. Because you can't have a solution if you don't understand what the problem is. So if you're given a problem of aggression as a presenting problem, and you haven't spent the time to understand the etiology of that, then you will not have a solution. There's a problem we have with diagnostic overshadowing because somebody has, which is a term used that with everything is attributed to a certain diagnostic quality, which, you know, might be substance use, but in our case, developmental disabilities. Who has developmental disabilities, everything sort of gets attributed to the fact that they have IDD. And that's, you know, especially in, I think, the crisis system, the individuals the crisis system is encountering are having stressful, you know, things happening and might be displaying something like aggression. And so they don't get to go to, you know, the Special Olympics tournament or some other place where you get to see a lot of people having a really high quality of life and really exciting, you know, wellness experiences. So I decided we would, because I don't like to just talk, I like to play games. So I put up a little game here, which just click the slide once, right? Now, I thought we'd break into sides, you know, we only have an hour, so so I'm actually not gonna make you be highly competitive, as I know you all are. But I thought you could maybe shout out a few answers. So this is the most common to least common findings for presentation in emergency rooms. All right, this is sort of scientific, came out of the University of Massachusetts, we just turned it into a little fun game. So you have this group of people who we've somewhat described with intellectual developmental disabilities presenting to emergency room. What do we think the reason for their presentation was? Anybody? Assaultive behavior, which is someone throw it on there. So assaultive behavior, I don't have as a category because that's a presenting problem. I want to say what's the findings for the acute presentation. So Darcy, stemming from that, and I've known Darcy, I haven't seen Darcy in years, but it's so good to see Darcy again. So Darcy, what do you think is the underlying etiology of aggression that we might find on this board?
Let's see. I know an ED would just say aggression, right?
They would, right? They would say that's the presenting problem, but we're hoping for the findings of that. So because I kind of used the aggression slide, I'm gonna slide Darcy off the hook here and say that we're gonna click on that as the number one answer. Okay, just click number one. Click number one for a minute. And you'll see developmental executive functioning considerations. So there is some truth to this diagnostic overshadowing in that when someone has a neurodevelopmental profile, they have a genetic condition, there's something that influences the etiology, the intellectual developmental disability, such as executive functioning. This ability to adjust to stressful circumstances, we look at recent changes. When we're doing crisis evaluations, a lot of the questions we're asking is about recent changes in someone's life, because the stressors that causes some of these executive functioning issues, which might lead to a more distressed presentation, right? Which can look like aggression, can look like self-injurious behavior, can look like property destruction, can look like a lot of things. But this executive functioning developmental consideration is important, but it's not a presenting problem necessarily, right? So we'll group that in under this group and say that's the number one answer, right? Okay, anyone else? So think of.
Here, let's try out our new mic and see if this works.
Anna is signing, she said, do you have the time to listen to? No.
Underlying cause.
Yes, the finding for why people are presenting.
Anxiety.
Anxiety is number 3. There we go. See, Anna's feeling it already. All right, see how easy this game is, folks? Anxiety promotes fight and flight, right? This is common. We all know a little bit about anxiety. We all have experienced it, but not to the level that causes necessarily, you know, inpatient psychiatric or medications, things like that. But, you know, you look at ASD 1 in 56, there's a lot of sensory issues, right? With that population, sensory sensitivities, other associated challenges with I mean, I can't imagine starting as a young child and trying to get on the bus and go to school and the anxiety that you feel being different, not learning the same. Some of the things that those anxieties that are every day that become cumulative for this population is very high. If you have some neurocognitive and executive functioning deficits, just functioning through life can create some anxiety. But it gets a little beyond that when you start getting into, what does that presentation look like? So if I'm anxious and people aren't recognizing that as anxiety, that anxiety just continues to increase. It might lead to an ER visit, right? Or might lead to some aggression, which also leads to an ER visit, to Darcy's point. All right, anybody else?
What about physical pain or discomfort?
Number 2 answer. Woo, there we go. HEA coming through. I mean, they're the whole person care. Number 2, please, click that. That is medical problem or and I'm also including medication side effects because we have an amazing ability because of number 1 to prescribe psychiatric medications, which then have side effects that lead to medical problems, which then lead to more ER visits, right? So the Surgeon General's report, David Satcher, 2002, was called Closing the Gap. I don't know if anybody ever read it. 2002 was a long time ago. We still haven't made any progress on getting physical health concerns dealt with for people with intellectual developmental disabilities. So there are, I mean, you saw on that list of aggression, constipation, teeth pain, all these things that a neurotypical, or if you didn't see somebody that this overshadowing of the fact that they have a disability that impacts our ability to interpret medical problems. And in emergency rooms, to Darcy's point again, they're gonna write aggression down. And I will say to the emergency room, can you check for constipation? Can you check for COVID? Can you check for this? No, I'm sorry, they're here for aggression. Well, we're missing the underlying finding here. It's the number 2 finding. We all can access primary care a little bit easier, although my wife has like 3 months till her next appointment that she's able to get into. But these individuals have trouble accessing that. And the more impacted you are with resources, the less chance you're gonna be able to get into that, and you're gonna have to use emergency room care. We don't do a lot of studies in the US. I'm going on a tangent here, but I'll go fast, Jamie, I promise. The province of Ontario, which I think includes Toronto, so at least has one big city in Ontario, Canada, did a study on their entire population of intellectual developmental disabilities. Her name is Yona Lumsky. You can look up any studies that she's done. But she found that 50% of people with intellectual developmental disabilities utilize the emergency room in 1 year in Ontario. 50%. That's a lot of crisis usage and emergency service usage by a population that should be able to access it. All right, anyone else? We've got the top 3.
Okay, let's try it on you, Mike, and see.
New mic. It's not even working. There we go.
It is switched on.
I can project, I think. Basic needs.
Basic needs. That's a. It didn't really exactly fit into mine, but I'm gonna loop it under 5 for the sake of speed. So if you click number 5, the actual answer I have there is caregiver burnout, right? So, caregiver burnout is an interesting amalgam of factors. You look at the transaction between the skills of the carers. You look at the resources available. You look at the basic daily supports that people have. You look at the degree of challenges and how long that's been going on. There are some amazing carers out in this world, and I think we'll hear from some today probably. But the idea that that this is going on and not getting any relief leads to these kind of burnouts. You're not able to get your basic supports, you're not able to get your daily needs met. So I'm gonna loop that under. Does that work for you?
Yep.
Okay,
Yeah.
very good. You got 10 points for your team. Anyone else?
See this first. David. No, nope. How about this one? I think that, nope. Okay, I'll just project.
That's all right.
David, it's coming on about.
Okay, we're gonna go. Number 4 is trauma-related responses. People with intellectual developmental disabilities have super high incidences of trauma. And this is it's the big traumas that we know about, physical abuse, sexual abuse, neglect. And then there's a bunch of what we call little traumas that hook into people and they're just hard to pull away from. You get enough little hooks in you, it's this cumulative trauma that comes all day. I could talk about PTSD as a whole entire day's lecture, but I'm getting rushed, right? So, number 6 thing is depression, because now we're getting into our mental health characteristics because, this is people with intellectual developmental disabilities actually have higher incidence of mental health issues. And again, one of the protective factors for mental health is cognition, right? Is being able to understand your role, how to get out of it, how to learn and develop new coping skills, how to have interpersonal relationships that make it stronger and give you more of a network of support. So all those things help alleviate mental health symptomology, and people with IDD are missing some of those. Okay, so depression, number 7, we're just gonna whip through these, is mania, and number 8 is psychosis, and there is no 9 to 10, that was all I did, it just, I didn't know how to erase them. So, again, mania is an interesting presentation, people that have, on the first, one of those earlier slides, emotional regulation issues, those are when, you respond, emotionally, which some people like to call rapid cycle bipolar. That is not rapid cycle bipolar, that is not mania, those are emotional regulation issues, so, although, like I said, these things happen at higher incidences than they do in the general population, and are certainly present and should be screened for when you're looking at emergency room visits, although they are not necessarily the top. Okay, that's our baseline setting. Hopefully that has given you some idea about what crisis response might look like a little differently for these individuals, and we're going to get into our panel discussion. And I have some questions here.
David, can I interrupt?
You can do whatever.
I request that folks would actually really love to get a quick introduction to each of our panelists. So maybe we could start with asking Jermaine and Raquel in there to say who they are, and then Raquel, would that be okay with you?
Yes, Jermaine was getting bored anyway, right, Jermaine?
No, I wasn't getting bored. I was just trying to process all of what I was hearing. But my name is Jermaine Hayes. This is my wife, Mikhail Hayes, and our son, his name is Cabrian Hayes. He's 10, and he suffers every single day. And some days you sit back and you ask yourself, is it really necessary for him to have to really suffer the way that he suffers, because nothing's readily available for him. He's been in crisis a number of times since he's been born. He's only been here for 10.5 years. But when we say we're in crisis and we show that we're in crisis, and the medical professions are acknowledging that we're in crisis, but yet and still we're told that nothing's available for 6 months, 12 months. He's too young. Or he's too young for certain programs, that has longer term care, and I don't know if anybody realized that, being his parents, if our mental health is strained because he can't get what he needs, then how are we ever going to really be successful with getting him to a place to being able to be a functioning human being in society? Because I would hope that would be the ultimate goal for everybody, is to get these folks to a place to where they can function on their own with confidence and things like that. But the system is so slow and so backed up. And my son is getting ready to turn 11 in November. He still can't read. He still has the same aggressions. And I don't see anything getting better. Everything is age related. He got diagnosed.
I'm gonna get into more.
I'm sorry, I can get carried away.
I think you gave us a good picture of you and Mikhail's you know, situation for sure. But, and so Jermaine and Mikhail, you begin to hear a little bit about them. They'll be answering more questions as we move forward.
Okay.
Also on the panel over here, we have Heather.
I'm Heather Getters. I am a stabilization specialist with Developmental Disabilities Administration.
Let's see, oh, this works now. Folks on Zoom, is that better? Let us know. Oh, sounds like it's much, no?
Yes, that's much better.
That's much better. Okay, I'm gonna hand this to Deanna to introduce herself.
Sure, hello, thank you. I'm Deanne Adams. I'm also with the Developmental Disabilities Administration here. And I will say, I don't think I'm comfortable introducing myself as an expert. However, certainly do have a perspective managing our clinical supports team, which is meant to provide support to families, individuals who are experiencing these drastic gaps in systems and services. So happy to be here today.
My name is David O'Neill. I work at Sound Health. I'm the director of IDD services there, and I have taught a national mobile crisis responders course on working with people with IDD, and have presented it the last 2 to 3 years to people from all nations.
Hello, Katrina Davis. I'm sorry. I'm a case manager at Seattle Children's Emergency Department, serving just the ASD IDD population in cycling crisis. I am also a family advocate, parent perspective, case manager, resource person for the Autism Echo IDD that we're doing across the stage. I can tell you more about it after the meeting if you don't know about that. Jermaine and Mikhail, I want you to hold your head high because what you did is, I'm a parent too. I'm a parent of a 25-year-old. I am spring-loaded to tell the world about the challenges he faces. He's profoundly autistic with IDD, intellectual disability. You're gonna hear more about him in my testimony, but I get it. You just want to know because it's so exciting to be in a room where people care. And I will listen to it. Thank you.
Hi, my name is Deborah Hughes. I am the Clinical Supports Director for Home Human Services in Tacoma. We're a residential agency and we support adults primarily with intellectual disability and dual diagnosis of complex mental health disorders. And we also have a crisis diversion program, bed-based program.
Hi, my name is Jim Lott. I'm a program manager with the King County Developmental Disabilities and Early Childhood Supports Division. Manage a number of programs around outreach, engagement, and 2 in-home behavioral support programs that work with children, youth, families with IED who are approaching crisis or in crisis.
They took your name down. Great. Okay, we have 3 questions we're going to run through. We're not going to go in any particular order, but we have adults and youth specialists here, so to hear all the experiences. So first question is, what are the unique needs of adults and or youth with IDD who are experiencing a behavioral health crisis? I don't know who wants to start. Oh, I see Katrina, Jim. Boy, people are chomping at the bit over here. All right.
Okay, so how much time do I have to make sure everybody gets to talk? But let me talk.
We have about 10 minutes per question.
Okay, well, I'll make sure we get to talk. So working in the ED at Children's, we see waves of this population coming in, and I want to make a distinction. So when we say ASD or autism spectrum disorder, intellectual developmental disability, there's a wide range. I know we've gotten away with, we're moving away from the IQ qualifier, but my son has an IQ of 50. There's a big difference between 50 and 120. There's no denying that IQ matters and it impacts abilities and how we function in the world. So when we're talking about this population, there's kind of a level 1, and I don't like to categorize people because a level 1 person, very maybe less needs or able, has hard days, right? But a level 3 person who's level 3 autism, which is profound, who has intellectual impairment, and profound autism is autism, which is social behavior communication. But the communication is no to little communication, not to be confused with our autistic population that can communicate or keyboard. My son is limited communication ability. It's intellectual disability, which impacts reasoning and executive functioning and just living in the world. Very high support needs, line of sight care, support for all aspects of daily living, toileting, bathing, dressing, eating. That's what I'm going to call profound. And then there's, and I think, again, I hate to use categories, but their needs are very unique in that profound category. That's the population I serve, that's the population I live for, because my son is that, and we spent a lot of time in the ED when he was teen years, when he was blowing out. We didn't know what was going on. As a parent, and I get emotional thinking about, it's pure fear when you don't have services when your child needs them. You sit in the basement, seriously, standing by the door, with a locking pad. Significant challenging behaviors can be very difficult as a manifestation of disability, and not something that goes away with just certain types of therapy or multidisciplinary team. It can get better, but it's a lifelong thing. So this population, I'm drawing attention to them today when I talk, because we're going to talk about different populations. That population right now is unethically underserved. DDA, those services, the contracted providers for Developmental Disabilities Administration, the providers aren't mandated to serve this population. If you're a caregiver, or you do specialized rehabilitation, or you provide respite, and you can pick who you serve, you're going to choose the easier people because you'll get paid more to serve the harder ones. So it systematically excludes this higher needs population, and we're feeling it. DDA, ABA through Medicaid, speech, ABA, OT, those services through Medicaid, same thing, even worse with ABA. Try to get an applied behavior analysis for challenging behaviors for a teenager or an adult, almost impossible. And then lastly, schools have to serve this population, but they struggle, as you can imagine. And DCYF, our CPS services, they often just defer to DDA. They'll go, oh, that's a DDA. So we have a really hot potato situation going on. You should attend one of our care planning meetings when we're trying to get a kid out of our, because little colleagues over there, parent meetings with them. When we're trying to get a child discharged, the parents are saying, his needs exceed what we can do safely in the family home. I'm not lying. I'm not kidding. Every parent has their resilience levels. But, so I'm gonna stop there and just say that I'm just so thrilled to be here with my colleagues and to be in a room where people, thank you for caring about the IDD population. I don't think people realize how bad it is. I know a lot of populations say that. Gotta check it out, gotta dig a little deeper. We gotta change things in Washington. I know we can.
Jim?
Thanks, David. I think, again, and I'm not an expert either on around clinical or diagnosis, but I fund a number of programs where there is a lot of expertise, and so I think that, you know, there's a need for rapid access, like calling up crisis line and getting a mobile response from program that's skilled in crisis intervention and stabilization, team members, and with skills, working with people with intellectual and developmental disabilities, with lived experience either through siblings or prior work, but that I think experience is key. And then well, I guess those two things are really key, but the response needs to be right away because individuals and families in crisis can't wait. And then staff really need to be skilled, a lack of skilled staff in the workforce.
Ever you got an answer?
I do, and again, I'm by no means an expert, but I have been working in this field, in this country for the last 8 years, I think I can do that. And I've also worked in this field in both Australia and Scotland. And I will say that there are definitely service differences that I have noticed between the nations. But when it comes down to it, I think that there is, everyone's heard the same, right? If you've met one person with autism or intellectual disability, you've met one person with autism or intellectual disability. So there are various unique needs of every single person. They all have their own unique needs and challenges. And at the same time, there are a lot of common challenges between the neurodiverse population. So I think that education piece of what those commonalities are, because most consistently, regardless of exact diagnosis, there are communication challenges. There are social interaction barriers. There are significant cognitive barriers. There are emotional dysregulation barriers. There's limited distress tolerance as compared to the neurotypical population. And then one of the more important factors is there's limited empowerment. So just from the outset of being different and needing additional support in most aspects of your daily life, like that's just empowering every single day. sometimes every hour of the day. And then trauma, so we mentioned that earlier, on days, kind of key topics of advocacy, and I've actually learned a lot from Dave with regards to that, but at a bare minimum, there's the trauma again, every day of being different, of that kid going on the school bus and seeing all these kids that are not responding to the same stimuli that they are not having more difficult of a time. And then there are a lot of studies out there, so children that have intellectual disabilities are 3 times more likely than the neurotypical population to experience actual trauma, so actual abuse, physical, emotional, sexual abuse, and neglect. And then adults with disabilities are 5 times more likely than the neurotypical population to need mental health crisis supports.
Yeah, Heather, everything to add around unique needs?
Can I just say really loud things instead of using that?
That's up to the Zoom.
That's okay, that's okay. So the unique needs, as DDA deals with them, and Katrina brought it up really well for us, is we have a lot of things that we need to do that we can't do. And the problem is wait list, funding, whatever the case may be. But we also have an experience of, in many of the hospitals in the area, the non-understanding. I work with the entire age span from children to adult, in a variety of different settings. And I've experienced hospitals coming out and just saying, oh, we can't serve this. And everything. I had one hospital actually tell a family, he has no quality of life. And so getting those kinds of things under control, getting staff in places is a need that really, really needs to be followed through with. Our clientele, they are meeting every brick wall known to man when they come into the hospital. When they come into different settings that aren't as well versed as Katrina and her folks, which are really great, don't get me wrong, but there are several hospitals in the area that are not. And the frustration that these families and these clients go through is immense, and it just aggravates the crisis.
David, I think Jeremy wanted to jump in there,
So one thing that I have on my mind is the time, the proper assessment of the time needed to actually treat certain conditions when you do have your kid in a crisis. My son, he went to IHS in 2022. And he stayed at IHS for 90 days while he was in crisis. And then he got sent home to the same environment that was already classified as triggering for him. And then a few months after that, a bed came available for CLIP, which he did very well when he was at CLIP. I don't have anything bad to say about the program. It's just the length of time, because he was notified that he was on his release date, what his release date was. So when he was coming home, doing his home visits, trying to reintegrate himself into home, he was rapidly digressing in his behavior. And then it was other behaviors that was picking up that wasn't even a part of the problem when he first got admitted into CLIP. And that was the whole sexual misbehaviors that he started developing. And we have 2 younger kids at home also, and their stress level is through the roof. And now that my son hasn't had that proper setting or proper time to actually be treated, and to the point where he can come back home and be able to practice those skills that he learned, those coping skills. It was complete failure. It was an absolute failure. And then when we reapplied for CLIP, we had more information than the first time that he got accepted to CLIP. And when we reapplied, he got denied, which was completely mind-boggling to me and my wife. Like, how's he being declined? And he has doctors and therapists that's pleading with y'all that he needs long-term treatment. He's not going to be successful at home until he gets long-term treatment to where he can actually be in the setting long enough to where he can practice on that, because he has extreme intellectual disability. He doesn't understand things. Each day seems different to him. So what works today don't work for him tomorrow. And those things I feel are being overlooked and everything. And that's about as far as I want to speak on that.
No, thanks, Julie. Yeah, that's super articulate, I believe. I'm just gonna hit these as the way I heard them. I mean, Jermaine just started there with, the availability of services as well as the length of time of services and the fact that you get declined for services. It was kind of mentioned before, there are wait lists. The fact that I think the siloed nature of care and Medicaid in and of itself, you're in a clip bed, so then all the other work that might be happening in the environment may not be able to be paid for at the same time, so you're not necessarily restoring or changing returned environments. Talked about the differences, IQs, high support needs, schools was brought up. Some of the hot potato of who wants to pay for this. Needs are exceeding what families can do. We need skilled staff and a lot of understanding education around this population. I know that workforce development is a challenge in most places in mental health and in the developmental disability service system. We talked about rapid access needs for quick crisis response to go out and do something. Sometimes just showing up and being alongside people and providing some oxygen and hope is helpful. Talked about the ability to empower, the impact of trauma. I think that kind of hit on some of the unique needs. So that was my quick summary. Next question we have is, given these differences, these unique needs, what are the implications for the behavioral health crisis response system? So, in other words, how do we want to approach crisis response system improvement to support these adults or young people with other need? So I will start that with Deanne, since she didn't get an answer on the last time.
I think implications in terms of being able to share with this group who is working on developing protocols to be responsive and also to the entire community. It's really important to know that DDA has significant developmental disabilities administration, that I think the assumption would be that we are funded to provide these really tailored individualized supports, is not in fact able to often provide, especially in the crisis services area. Part of the role of my team is responding to hospitals that are calling in crisis. And over and over again, I feel like what I coach my team most on and am there to say in meetings is, we need you to understand the limitations of our services. Most often a hospital says, DDA is here, great, what do you have? Frankly, we don't have a system that is robust enough, that is tailored enough, that provides a continuum of care, and especially fails in the crisis response setting. So in terms of what you all are doing and building, it is so important to understand that piece to develop the training and capacity to respond in crisis moments in tandem with the services that DDA does, while we internally, and also with great advocacy from, I want to say, children's, by the way, our colleagues here that do great advocacy, making sure that somebody's paying attention on where the gaps are within DDA, and the funding that we receive is really critical. So just to be clear, that misunderstanding, I think, can be really problematic. Law enforcement can think it, hospitals, mental health providers, this diagnostic overshadowing and exclusionary criteria, we see it in all cases. We see it in just general standard referral for mental health counseling. You see it in schools, you see it in hospitals across the board, and especially when it comes to crisis response. So I'll stop. I can go on and on. I really appreciate this really important conversation, and pass it.
I just want to add like a quick thing to what Deanne said. A lot of times we get told, or we hear things like DDA has this program and DDA has that program, and that's true to a certain extent, but what's not recognized in a lot of cases is that our programs are served by contracted providers. And so this kind of goes back to, I think, Katrina, you were the one that said it, is they can pick and choose. You know, we have supported living, we have these things, but these are outside providers that are contracted to us. So if they choose, for whatever the reason, to take a certain type of clientele, that's where our hands are tied. And that does become a huge problem.
So I know you're probably hearing a lot about the problem, but it will build up to some recognition. So I'm gonna go back to the profound population again, because we're talking about the entire population of IDD, right, and ASD. I'm talking about the profound just because one that's near and dear to my heart professionally and personally, but also I really need to make that distinction that they are systematically excluded. Services exist, DDA, caregivers through DDA, respite, specialized rehabilitation, housing, residential, location supports. But you know how many times I hear this person's needs exceed our model of care? Unbelievable. And what that does to a parent is like, well, who does this? So what happens, that's what leads to the silent crisis. If you can't get the respite or the ABA, then it leads to crisis. So up and downstream. So then maybe you get into a facility. And by the way, folks, we have patients who are routinely, they cannot get into our inpatient mental health providers because they can't participate in talk therapy. So they're excluded because their needs exceed the model of care. They can't fit the clip. We deny people with profound autism the clip and IDD. We also 988, beautiful concept, and I know a lot of people use it. They will often refer to DDA. Sorry, folks. But you know, it really is this funny thing is we have to really pay attention to this population that is truly being excluded, and not to say it's easy for everybody else. Lord, you know, the level ones are struggling too. So what this is leading to is out-of-home placement, and not just out-of-home, out of state, because we don't provide these services in Washington. People have to leave, people with intellectual disability have to leave their family, their home, their school, their community, everything they know, to go out of state. Again, I think of the word unethical, it's not okay. We do have now Lake Erie Transitional Care Facility, which you can talk to the DEA folks, but it's 24 beds, might go up to 12. And we're still concerned they might not serve this population. We're afraid we're gonna hear their needs exceed the model of care because it's not a lot of facility. And I'll just say this, we worked really hard, Rashi and others worked hard, 1580, you know, this House Bill 1580 we can tell you about. That's cool, and that's gonna help create creative solutions and maybe bring these silos together, need more of that kind of stuff. More ability for these systems of care to be sanctioned to do things they normally can't do, you know. And money, hello. But then I'll just say that home and community-based services, advocates have worked really hard that we get our people out of institutions, right? I don't want to put my son in an institution. He ended up at CRIS because there was no one else to go, and I had finally help to get him in there because we're closing them. But what happens is people who require an institutional level of care, and I'm sorry, some do, they just can't. Home and community-based services aren't enough. They expect parents to manage a kid who requires an institutional level of care without support. Okay, so we gotta find longer term solutions for this population so they can return to their community. That is huge. And I'll just stop there. Thank you for listening.
Yeah, maybe we want to jump to Jermaine and Mikhail, because I think that what Katrina just said played into something you said about that accessing those services, longer term solutions. Did you have any other system improvement ideas or approach to crisis response that expands on that?
No, what she just said was pretty much everything that we have been saying for the past 10 years. So no, nothing more than what she just said.
Appreciate it.
I will just project my voice. So we've talked a lot about system improvements, and we could literally go on all day about that. And yes, there are huge systems gaps for youth, but I primarily serve the adult population, and it is 10 times worse for adults. As soon as they age out of school, then trying to access ABA services is a nightmare. Trying to access any additional services is a nightmare. As soon as they hit that age, if they have not had the right clinical diagnosis documents, trying to get them re-diagnosed for something that's been in their record their entire life is an absolute nightmare. So that advocacy and that chronic system of just reacting and not looking at the underlying problem and the underlying prevention strategies and systems and resources, it constantly snowballs, putting people's lives in jeopardy, frankly. But I actually took it from a more practical standpoint, because I am often the one that gets called in when these crisis situations occur in my agency. So one of the biggest things, both within our agency, from the individuals that we support, as well as from family members, is quicker response times. And I understand that the MOPS teams, the DCRs, they're all doing the best that they can, but the process itself is so cumbersome. So to walk you through it, in our region, in Pierce County, you have to call the Pierce County Crisis Line. That initial screening takes minimum 5 to 15 minutes if you're an outside, like, regular person of the population. I try and skip that whenever I can, and I just ask to be put through the right line, but sometimes they insist on the initial screening. And if it's an individual or a staff member calling, they have to do that initial screening. They then get transferred to the provider line, which then is another screening. They then have to wait 20 minutes for a callback, which sometimes occurs and sometimes does not occur. And then they have to restart the entire process to then finally speak to a clinician from the crisis team, to then be told it can take up to 2 hours for in-person response, or sometimes even longer than that. So you're looking at a minimum 2.5 to 3 hour process to try and get support in a crisis situation. And as soon as aggression is mentioned, that person has made aggressive acts, they're like, no, can't help. You guys have to call 911. And then sometimes they turn up, sometimes they don't turn up. So in terms of the biggest improvement that could be given is actual response in the crisis situation. And then secondary to that is follow-up. So how many years have I been working in this area, in this field? And I just found out literally less than a month ago that it is possible to request in-person follow-up for a post-prevention from a crisis situation. I just found that out 3 weeks ago. Prior to that, I had heard about follow-up. Most of the time they're phone calls. Phone calls and telecommunication is not the best way of communicating with our population. So in-person is definitely preferred. And that in-person follow-up would then potentially prevent a further crisis, because the amount of times that someone then cycles and is in and out of crisis and reaching out to crisis support or going to the hospital multiple times in 1 week, that could be prevented if there was that post-prevention follow-up and coordination with the existing services that person has in place, like sound. I'm so thankful that sound exists, because to my knowledge, they're the only mental health agency in the region, if not potentially the state, that has a dedicated program for the intellectual disability population. It is so hard to get services. And then when you do find an agency that is willing to serve our population, you come across the barrier that Katrina mentioned of, oh, they can't participate in traditional talk therapy, so therefore they cannot access services. And basically telling them they don't deserve services. They don't deserve grief and trauma support for the loss of their mother that they talk about every single day, because they can't participate in traditional talk therapy. I have that in writing from like a leading mental health agency in a region, from their director of services.
Jim, can you, I'll start with you next unless you have a quick.
I saw Jermaine like on his hand.
Oh, yeah. Hey, good, thanks, Jermaine. You're tiny up there. I'm blind.
This is just real quick, because it just came to my head while I was listening to y'all speak. My son, he has therapists and specialists that he's had for years. And he builds relationships. He actually looks forward to seeing some of these therapists that comes in. But it takes a while for them to build that relationship with him and for him to let those guards down. It seemed like no sooner than the relationship is built, that therapist or that psychologist has to leave. It's no consistency as far as the care goes. And when you're dealing with a kid who has problems dealing with transitions and change, you know, that's a big thing to my son in particular, because he does hold relationships real strong. And when he has that, and that service is only available for 3 months or things like that, you know, in my opinion, that's doing more harm than good to certain kids. Maybe not all, but to a large amount, in my opinion.
Great, thanks, Jermaine. I'm gonna summarize that question real quick so we can move on to the last question, which we'll start with Jim since he got gypped that time. Given these differences, what were the implications for behavioral crisis response systems? There was the quicker response times came up again, comes from process. A little bit kind of leaned into the overuse of 911, but there's a lot of co-responder models out there that I think are providing some new help in that area, so that telehealth, et cetera, is not necessarily the best for this population. That we need more mental health supports and accessibility to these systemic exclusions. We need a little bit more inclusion. The consistency of care that Jermaine just mentioned around this building relationships with workforce issues. You have, new therapists every 6 months, then it's likely not going to build a lot of development here. Clip of services at the age difference between youth and adult, and don't always go to DDA. I got that. Mental health crisis response is a community issue, and I think we've talked. That's what you guys are all here for. So, including into that. So the closing piece, we'll make sure everybody gets a shot at this. This committee is developing recommendations for crisis system improvement. As they continue developing these, what is one key takeaway you'd like this committee to consider? So one key takeaway. I know that's gonna be hard for Katrina, but. Okay, Katrina has 3. We're gonna start with Jim then, right? Yeah.
Is this working?
No,
Yeah.
yeah.
Okay. I guess the takeaway is expand funding and the capacity of programs that are working in the community to prevent the use of ER or long-term out-of-home placement. That's been a goal of our division, is to develop programs, pilot programs that have a focus and a goal on that. And we have several programs that are working with families in crisis or approaching crisis. Really good outcomes around stabilization. These programs are working. They're just not at capacity. They're serving 40 to 50 families a year, when they could be serving double or triple that with adequate funding. So, yeah, I think the goal is to keep people out of the ER or out of long-term out-of-home placement. And so it's investing upstream in those programs that will keep people from going over the edge, and then having the outlets at the bottom there to treat them in treatment to emergency rooms and to other long-term and appropriate care.
Jermaine, one key takeaway. Or Miguel, if you want to chime in now, I know you got lots on.
If who's talking, me? Am I talking?
One of you two.
You want to speak? Okay. Well, one key takeaway that I would say is, it's a lot more people who are realizing that their kids are having issues more than what it was when I was young. And I would just say that I would hope that everything is heard and acted upon, and for a better system, yeah.
Great, thanks.
Can I answer? Can I answer the previous questions? I got sidetracked and ended up giving my answer for the last question. Just because I got a little bit passionate. But just in terms of
our population, they are just as deserving and, as statistics show, even more in need of comprehensive mental health supports. And that prevention and postvention is what is going to break the crisis cycle. And then some of the more practical kind of implementation options of suggestions really will focus on education. So education for first responders and education for clinicians. The responders that are coming out to deal with the IDD population in crisis do not appear to have a thorough understanding of IDD and the intersection and the difficulty that poses, and that the person cannot engage in traditional crisis de-escalation strategies. And even just the awareness to ask, does this person have an alternative communication method? Does talking to them not really work? So like that education is so important. And in a previous life, in a previous continent, I was part of an education initiative for the Queensland Police Force in mental health awareness. And I think that a version of that where it could be a lot of information diluted into understandable segments in a few hours would go a really long way in if there could be some sort of education program about neurodiverse mental health awareness for first responders, as well as that additional clinical training.
So again, I'm gonna focus on the profound needs of the profound population. So, you know, we talk about aggression, that is the number one thing parents talk about when their son or their loved one is more profoundly impacted. Aggression, because that's a form of communication, right? Behavior. And so we're not talking about little tantrums that require timeout, we're talking about biting to the bone, poking eyes, head banging to death, detaching redness. We see that. It's really extreme behaviors and harm to self and others that requires medical attention. Bolting unsafe from the home, into traffic or bodies of water. So that's the kind of aggression I'm talking about. So when you think of that, you know, the parent calls 911 because they're told to, they go to the ED. They often hit baseline because, you know, the ED is not a treatment center, so they're discharged. And discharge means you go home either over medicated because you choose that. I chose that for my son to keep him safe. And he's worked out, not cool, that's unethical too. And then the cycle repeats, you go back to the ED. So, and then some parents just say, I decline discharge, I cannot take one more day of this. Now, just like we don't want to for everybody to DDA for things that they can't do, EDs are not holding tanks. They're not as safe, and it's the most restrictive environment. We really care about restrictive settings. Stuck in an 8x8 room for weeks and weeks. That's what's happening, folks. So the ED is not a solution, and it should never be a solution for what we're talking about, trying to improve someone's health and well-being. So my thoughts are about ideas. Parents like us and families, we need immediate placement, not an ED, but a place to go that's safe, where a person can go and get a highly supported environment. We can't go to the inpatient units. We can't send them there. We have to have a unique place that's just for this population. We also need the world to acknowledge profound autism and IED exists, because we don't like to label people, but it's a real thing, that seek to understand their unique needs, which are often very different than what's being offered. Also involve the parents. Nothing about us without us. When we're talking about profound, parents have the lived experience and they speak on behalf of their child. I know they do their best. I'm sorry my son can't serve on committees. He can't, but I'm here to do my best to represent him. So involve parents of this population. And please know that parents, make this quick, we've been asked to do things over and over. Oh, just go find ABA. Please believe us when you're setting us down a rabbit hole. And yes, these services exist, but we can't find them there, can't find providers. My last recommendation, so besides you can understand, then build the unique services for this population. And finally, 988, I would love to see a 988 for this population. Because when we call, we get referred to the DEA. Sorry. So let's talk about, or pull the 98, create it where they can serve this population. Maybe there's a subset of providers that serve this population. We need soldiers in the home quickly.
Yeah, Heather?
Sure, I'll just say briefly, I mean, 100% agree with everything that's being shared. I would add that using Katrina's term of the ethical responsibility here, we do have an ethical responsibility as a community to come together. When I share that DDA can't solve it all, DDA absolutely is at the table, needs to be at the table, we want to be part of conversations about how to solve it. So I will add, every single region across the state has a clinical team that can and is created to really try to partner with other resources to figure out how to do this. We're not asking that this room solves it on their own, right? But we do need partnership, and that would be the one thing I would ask, is if you're kind of creating plans, looking into what does training look like, how to better understand the needs of who can provide what. We're happy to help sort of reach out and make those connections, because I think that misunderstanding is a big one. Until we can figure out who can do what, then the systems are gonna keep failing, in addition to all of the other great ideas that you shared.
And of course, I'm gonna support everything everybody here has said, because they've hit everything I've considered saying. The one thing that I do want to add is, we really need to expand. We need to expand on everything we're doing. Families are suffering and are able to get a caregiver. And I don't think something that's widely known is the caregivers that are available aren't qualified. Our caregivers at any level are basically folks who work with ADL. So just, learning to eat, learning to clean up and stuff like that. They're not able to handle the level of aggression that can come around. And so we have families, both of adults and of children, that are suffering day to day because they've got no sources of exit, no sources to take a break. And everything, so expanding and then streamlining everything, because like Katrina and everybody's talked about here in the hospitals, we're talking about weeks, days and everything while we're waiting for an approval for this and waiting for an approval for that. And this is not sustainable or safe.
All right, that was our last question. I just wanted to do some quick summaries. There was again a lot there. Someone's probably taking better notes than I am, I'm sure, because I already talked about my executive functioning deficits. But expand programs that are working, comprehensive mental health supports. There's a lot of talk about capacity building, just increasing the overall knowledge and education of the providers in all arenas, including lived experience. You guys have done that really well. I mean, you're spending the afternoon on that, so that's fantastic. Let's see. Yeah, I think when we talk about crisis in general, I think my own takes, I didn't really answer the questions, but crisis is an event, right, that happens. And it's that weird mix of the challenge of the day, the skill of the carer, the resources that are available, the supports that are available, all those kind of things that happen, that create this event. But crisis is a baseline and a lifelong experience for a lot of these families, as Jermaine and Mikhail and Katrina and others have shared. And so that's why I think you hear a lot of these answers that are much deeper than just let's address this immediate crisis moment, which is a great thing, but you have very little options when you're in crisis. You have a lot more options if we go, before and after with that follow-up and that preventative care. So with that, we're gonna wrap up this panel. Thank you again for this brief.
We might have a little time for, CRIS Committee members to ask questions.
We can do that. I just said our part. I'm done with this pile of notes right here. I'm retiring this.
Well, and may I just say, David, that was phenomenal, panel moderation. Yeah. All right, so CRIS Committee members, I imagine you're burning with some questions for our panel, so I'm gonna run the mic, especially for. So Anna, let's start.
Is there any information on how often people with IDEA crisis end up in the criminal justice system as a result?
Well, yeah, I mean, I was asking for we all have answers for that, right? There certainly are. You look at different etiologies, we know that the criminal justice system is full of people with fetal alcohol syndrome, right? Fetal alcohol effects, things like that. Depending on, again, what their IQ and their adaptive functioning is, that is a birth defect that happens in the womb, right? So that qualifies for developmental disabilities. That population alone, we know, makes up a lot of prison population, right? The understanding of what that means and how you treat that disorder. So I think it's drastically under represented for the people that are actually incarcerated. But I also think that the exclusionary criteria, no officer wants to take like someone with profound autism who's, you know, severely assaulting their family member, you know, and consider that domestic violence and put them in a jail setting. So you have, you know, again, the differences make it really challenging to answer that, but I'll let others answer that as well.
So I serve a wide variety of this population. So we have extremely high functioning individuals, and then we have people with extreme profound needs. And so yes, typically, thankfully, our local law enforcement are pretty understanding of those profound need populations. But actually, there's certain very maladaptive cycles with a lot of our higher functioning individuals where they are engaging in illegal behaviors. There is a level of intention behind it. It is premeditated, and it is a continuing cycle. And when we ask, like, we're not gonna ask in the moment, if someone's truly out of control and they're just overwhelmed, we are gonna advocate for them to go to a hospital, to be evaluated, ideally detained and have a breather. Now, that's its own whole kettle of fish, and that system, but then a lot of the time, they aren't getting the natural consequences that any neurotypical person would, and therefore it is leading to ongoing challenges. It is leading to many agencies then terminating services of that individual, so that super high needs individual who has not had appropriate intervention is then going back out into the community, sometimes without any services, sometimes they're homeless. And extremely vulnerable and extremely at risk. And while the behaviors may have been illegal, a lot of that is stemming from trauma. A lot of those individuals have an intense history of trauma, have intense underlying mental health conditions that have not been appropriately addressed because the services don't exist. Again, I'm gonna say I'm so thankful that Sound exists and that Dave exists and that he created the IDD program at Sound, because that is the only one that I know of that actually has those integrated services and focuses on the population. That yes, there may be other agencies, but the big guns, the ones in our area, Multicare, CHI, Franciscan, SEMA, they regularly exclude our population because they cannot additional talk therapy. And then just really quick, just because someone is detained in a crisis situation, and is deemed to need involuntary treatment, it is extremely rare that someone of the IDD population ever receives that treatment. There is one program, it was meant to start in 2020, I believe they actually finally opened their doors in 2022. They have a 16-bed program, but I believe only 8 of them are dedicated to the DD population, and that is the only mental health treatment facility that I am aware of that has any level of focus on the IDD. If you add that in, then they get excluded. So they may be legally deemed to need treatment and they will get stuck in that hospital room in the ED with no windows, no ability to go outside, or whatever the length of their treatment order is, whether it is 14, 90, or 90 days or 180 days.
If you want a resource, I was just gonna say the True Blood case might be which place to turn for there, and maybe get someone to speak on that. And then lastly, you know, our families are BIPOC families. Our behavior is threatening to people, so you can imagine our BIPOC, there's a disproportionate number of police involvement for BIPOC. Those are the same.
And I wanted to just add a little bit in regards to details. In my job description at this point in time, I'm getting between 2 and maybe 5 calls a month for clients that are taken into jail. And then, you know, we talked about aggression and being the source of that. That's actually not the only source. Our clients are the vulnerable population, but they're also the manipulatable population. So we have clients that are being picked up for doing something because a friend asked me to. And I think that's really kind of underestimated as being something that's happening. And they're facing charges for it, you know, whether it was theft, whether it was some kind of other shoplifting, whatever it may be. But it does happen.
Hold on. Multitasking here. Michelle, are you?
Sure.
I'm gonna grab a mic and get in front of you.
We can hear Michelle.
Make sure everybody can. So Michelle Roberts, Department of Health, thank you to all of you for sharing your expertise and knowledge and gaps better. At the Department of Health, we support the 3988 call centers who are in the room. And I think would love to have some follow-up, especially with DDA, like the likelihood of having a 988 call line specifically for IDD is very, very slim. And we can explain why, but I also think like we look at how we're staff being trained, but the idea of 988 is a front door to assess, de-escalate, and refer to other services. So I'm really interested in the gaps, like what would it take for DDA to be able to be that partner? I hear you saying you can't do it, but like what else is needed so that the 988 team could hand off to a robust system with the right supports, and really appreciate the focus on kind of the upstream outpatient, Jim, what you said, like the opportunities to invest in programs that will keep or hopefully prevent any of the crises from happening and create like longer term stability. So, but happy to look with DDA at how call center staff are being trained in this area, what opportunities there are, and making sure we have a knowledge of the right resources where we can be calling the shots and need additional levels of care.
I didn't hear a question there, so we're gonna wait.
I think we have probably time for one more question. I've had a couple of comments on Zoom as well, so Alicia. Okay, I'll go to Claudia and then I'll come back to Alicia.
That's very good. Thank you. You know, I just wanted to respond because I hear the name of CMAR as being one of those organizations who sometimes has an exclusive criteria, and it's so painful to hear that, but I want to tell you what we struggle with. I think that one of the areas that we're not talking about, we see a Latinx population every day asking for help with our pediatrician. And the pediatrician saying to us, hey, Claudia, you have to do something. When the client comes to mental health first, it's lack of training, absolutely correct. But nobody talks about funding. We have been finding so many times, but the Department of Health, when they come and look at the chart, or by managed care, saying, this is a diagnosis, this is a DDD, we should not be paying under mental health. And we get like many, many times, I think the issue is managed care of people who are reviewing the clients that we serve, is that issue of this is not mental health, this is DD. And when we send it to the other organization, they say, no, you need to do mental health. I think the issue is that we are so separate in terms of mental health is so separate from other services that we as a provider struggle. Many times we get our claims denied because that diagnosis is a secondary diagnosis of depression, but really this is a patient who should be treated by the other system. So I think that's one of the struggles.
Can I just ask what are the system?
Exactly.
There is no one, this is.
Exactly. I agree with you, and I'm so thankful because what you presented today is so helpful to me. Yeah, I think we struggle a lot in primary care and behavioral health, figure out what to do in a system that doesn't exist.
Thanks, Claudia. And for folks on Zoom, that was Claudia Dealer with CMAR. Take it to Alicia, and then I'll read a couple comments on Zoom.
My name is Lisa Morales, and I'm in the CARES seat, but I oversee a alternative response program that dispatches through 911 to crisis in Pierce County, specifically to Toma and Burgos. And so I guess the question I have, because we're talking about improving the crisis system, is if you're calling for an in-person crisis response and the hope is detainment, how often are you actually seeing that as a potential outcome? Because I know for our team, when there's a component of ID, often the response is that is their primary, much like Claudia mentioned. So they can't be detained. So then there's nothing. So I'm wanting to know if that's happening, and also is that at that point, who do we reach out to support, because we're voluntary?
Do we have everyone who can answer that one?
I wish that we had the resources to put stats together. You know, when you're actually on the ground in the field, like no one's gathering this information. As a matter of fact, the things we report to the mental health system, sometimes doesn't even have a checkbox if someone has developmental disabilities or not, right? So I don't know that we're getting data that would reflect the need for that kind of real focused care. So maybe that's the thing, maybe, the data does drive and inform decision making. So it'd be nice if we had better data. I would say that nobody wants to detain someone with IDD, right? And much to Katrina's point, we've had people sexually assaulted in psychiatric hospitals, right? There's a vulnerability there. There's the, they've also assaulted people in psychiatric facilities. So those aren't great places for this population. But, if this is an acute mental health need, that's the place we have to treat it. And I think what happens is we don't understand the acute mental health need, right? What does mania present like? What does psychosis present like? How can trauma be healed through a short inpatient psychiatric facility? Maybe not as effectively, but I think, do we have people detained? Yeah, we can all say we've got people stuck in emergency rooms, we've got people stuck and grave disability, that nice third criteria. We can always massage that a bit, but sometimes it just takes again that education, understanding of what the acute presentation is really for, and that gets to that previous thing about what's the etiology of the aggression that we saw here. It's not just developmental disabilities.
Can I add a little something to that on the detainment? Well, sometimes we do get people detained, which gives us the opportunity to help them. That's wonderful. When they get to a certain point in their detainment, we have had, especially recently, doctors who aren't well versed in our folks with IDD lift the detainment and literally street the client. Because the clients are maybe their own guardian or something of that degree, but literally discharge them to homeless shelters.
Well, I want to come back to something Jermaine said. Because someone has an intellectual developmental disability doesn't mean that they can't recover, right? This means that I think what Jermaine said is that it took a lot longer, right? I mean, it took a time to build a relationship. It took a time to understand the communication. It took a time to do this, and then impact can happen. Our crisis systems aren't designed for that level, that slower process, right? That longer time that it takes, especially when you're looking at all the differences that we've talked about today.
So I'm just going to briefly share a couple of comments from our CRIS members on Zoom, and I'm going to read them rather than post them to Zoom so the folks in the room can also hear. These are from CRIS members. So first of all, Vipasha Mukherjee says, on the crisis line, I've heard this often about people bonding with their counselor, and after a while that counselor leaves. It's deeply impactful for people to be able to trust care. It would be a lot harder for what's just lost it, I apologize. It would be a lot harder for folks with intellectual and developmental disabilities. The caseloads people have is so high it can cause burnout. We need to do better with paying people well, yes, but lowering burnout so they can stay longer term, which will in turn benefit clients, which is the final goal. There's another comment from Vipasha on the crisis line. And then here's from Puck. I used to work in mentoring, and there was research that found that being matched with mentors who were there less than a year was actually detrimental to mentees. I think the logic of this transfers pretty well to the supports of therapy with this community. I've lost my entire autism care team with a health insurance change, and it's indescribably painful. Finally, from Pat, Alicia's question is something I've suggested that we study before. What is the desired response that doesn't happen solely because we don't have the capacity for it? And one last comment to read to all of you. This was earlier one from Vipasha, I think in response to reflections from Jermaine and Mikkel, which was, we will hear an echo of parents needing to provide institutional level care for their children with disabilities at home with no support in our lived experiences story project presentation. Vipasha's referencing a presentation that's going to be happening after lunch. I think that's all for our time and our questions. So David, do you want to say anything in closing?
I think it's all been said. I think, I don't think it's insurmountable. I think it's just, you know, we have structures that have been put in place by committees that separate people with intellectual developmental disabilities from the traditional health, from mental health, like Claudia stated. You know, those are the areas we need to attack. You know, if I have to get, you know, I get a crisis referral that needs a Medicaid waiver authorization, which then can take a couple of days, well, that's not a crisis response, right? You know, so we put these barriers in place through committees and through the systems. I mean, when we talk about burnout, I don't think I've ever lost a staff because of an individual that they support. We've lost them because of burnout with the system that doesn't give them the resources to do the work.
For those of you on Zoom who may not have seen this, Cook was physically echoing the comment. I'm just gonna cry, I'm just gonna be autistic and crying in the corner, it's fine. This is a good place for that. I wanna say on behalf of all of us on the CRIS Committee, a huge thank you to this panel. Tremendous amount of important information shared. Jermaine and Michael, thank you so much for being with us today and sharing your personal experiences and caring for your son. And to our panel sitting in the room, just tremendous breadth of experience that you shared with us. And David, that really truly was phenomenal. Well done. Panelists in the room, you are welcome. We have lunch set up outside. You're welcome to stay.
That's the only reason I came.
Okay, good. You're welcome to stay as long as you want, but of course, there's no obligation. Everyone in the room, I'll give you some lunch instructions. Zoom folks, we're gonna be back on at 1 p.m. So you get a little break now and we'll get back together at 1 p.m. And for folks in the room, there's some lunch set up, boxes set up right outside these doors. 4 gluten and dairy-free options, 10 veggie, and then 18 chicken Caesar wrap and 18 Cobb salads. So if you have strong preferences, shove everyone out of the way, run out the doors to grab their books. And we'll see you all back at 1 o'clock.
Yeah, there's still a lot of feedback coming from other conversations though.
Okay, we're just wrapping up the conversation, so we'll get started. All right, welcome back, everyone. If you can see the other right. Oh, great, that's right in front of me. All right. All right, and if anyone's interested, we now have space here at the table, so any our folks in the back, if you want to go to the table, you are very, very welcome. Or if anyone wants to move, there's more options now. Welcome back. We have, as long promised, an opportunity now to learn from our very own Kristen Wells and Natasha Mukherjee about the outcomes and insights coming out of the Lived Experience Stories Project. That's what we're going to do for the next hour. So I'm going to ask everyone, they have worked very, very hard on analyzing these stories and putting together a presentation for you today. I'm going to ask everyone to hold your questions and comments for the committee members until they've gone through the whole presentation, and then we'll have time for you to offer your reflections and ask your questions of them after they've completed going through the presentation. And so with that, looks like Natasha and Kristen are on and ready to go, so I'm going to turn it over to them.
Yes, and I'm not muted. Yay. Okay. Hello, everyone. My name is Bipasha, she, they pronouns, serving on CRIS as person with lived experience. I was going to be there in person, but last minute issues prevented that. Kristen, you're on mute.
There we go. Now I'm off mute. Hello, I'm Kristen Wells, she and her pronouns, and I'm also one of the lived experience representatives on the CRIS. I see that the slides for our presentation aren't up yet, so there we go. We're excited to share with you some of the insights that arose as we read the stories from the Lived Experience Stories project over the last few months. Both Bipasha and I realized how much of what we heard this morning in the DD and IDD panel is echoed in our findings, so we really hope we can address all those overlaps in our discussion. Next slide, please.
Okay, first a little background. For the last 3 years, we've heard from folks with lived experience at our monthly Monday afternoon meetings and from those who are able to share their stories directly with us at the CRIS. But we know that not everyone can participate on a Monday afternoon. So our hope with this project was to cast a wider net and hear from folks, especially those from more marginalized communities. We collected stories through June and July. It's a small sample of people who were able to submit. It's not a representative sample. We had 65 valid stories that were coded, and insights about different parts of the Washington behavioral health crisis response system were drawn from these stories. Next slide, please.
These are the demographics that we captured during the project. Please refer to the detailed demographic slides in the appendix for information about each of these demographics. There's a few things we'd like to highlight about the demographics before we get started, though. In our lived experience subcommittee meetings, we've not heard much from folks who had substance use disorder, housing insecurity issues, or involvement with the criminal justice system. We're happy to report that we did capture stories from each of these populations in the Stories project. Unfortunately, despite our outreach efforts, we received very few first-person stories from young people, though we did receive some second-party stories that involved youth. Most submissions involved people who accessed the behavioral health crisis system within the past 2 years. Next slide, please.
Okay, as we move forward through the presentation, please note that for every insight, you'll see bubbles that are verbatim quotes from the stories submitted. Any words in square brackets are clarifications we made to the quotes. All acronyms are at a slide in the end in the appendix if you want to look at it. And for the presentation, we did whittle down the quotes that we're using. This is an important note, the next one. We have left the names of agencies and services that were in the original quotes. This is to honor the lived experience voice as they were shared. We have precedent for this, as you well know, that at the CRIS meetings, when we had people share their stories, we didn't tell them you cannot name an agency if they wanted to do that. So we're following the same guideline. It is not our intention to demonize or angelize any agency. We're trying to really honor the lived experience voice. We're aware that most agencies do good work. One incident or story does not determine the overall quality of care agencies provide, but the stories we're going to hear from can help us build a stronger, better system. So we're going to start with things that are working well in our current behavioral health crisis system. Next slide, please.
From these quotes, we can see that people are receiving help across the continuum and beyond. First quote, "My friend OD'd. I called 911, needed urgent medical advice. Immediately, paramedics arrived and had some drugs to counter the overdose, and my friend got stable." Second quote, "DCR was professional, kind, and caring. DCR even called every hour until the agency opened up." Third quote, "I was diagnosed by my primary care doctor with life-threatening liver, kidney, and pancreatitis disease due to my alcoholism. When I got totally honest with my primary care doctor and my therapist, I was referred to a detox and inpatient treatment." And final quote, I called 988 and gave them all the information I had. 2 people from Mobile Crisis showed up, male and female, in less than an hour. That was impressive. In addition to those quotes, we heard about a group home that was excellently run, PACT being very impactful, pun intended, a shout out to HCA for helping a client who was stuck with accessing services, and ED social workers who were kind and connecting people to ongoing resources. Next slide, please.
Okay, so now we'll move through insights from stories about things that didn't go so well for folks in their experience with the behavioral health system. Next slide, please.
Although there's a lot we could extract from these stories, these are the 7 big insights that resonated most deeply for us. As we go through each insight, we'll zoom in on some details and sub-insights that stood out. Next slide, please.
So our first insight is that the criminal justice system and emergency departments are functioning as primary access points to behavioral health care and the crisis system. There are 4 nuanced insights under criminal justice system before we get to the ED insight. Next slide, please.
Our first sub-insight is that stories involving the criminal justice system are showing that people are ending up in criminal justice during a crisis rather than receiving immediate behavioral health support. Quote, had there been easier access to a program like drug court, I could have avoided the multiple felonies I have on my record and had a supportive program behind me. Next slide, please.
This next sub-insight from the stories was that the criminal justice system is often traumatizing for people who enter it, which leads to or exacerbates behavioral health crisis issues. Quote, my first stay in prison was devastating to my psyche. I found myself in a world of which I knew nothing about. The fear and depression was contagious. It permeated every single day of my life, which I believe became the catalyst for the subsequent drug abuse and mental health problems. Next slide, please.
The next sub-insight is that while it's not preferred route to behavioral health support, some people are accessing helpful programs through the criminal justice system, which is better than not getting any behavioral health care at all. Ideally, people should know how to get behavioral health care early so their lives don't intersect with the criminal justice system. This is better for the person, their loved ones, and the community. Quote, while incarcerated, I was introduced to the Change program through Progress House Association. It was this program that ultimately helped me change the trajectory of my life. Knowing that there are programs, resources, housing, and hope helped me change my life. I'm very eager and excited about the opportunity of a new life. It is my goal to tell others that they can make it just as I did. In addition to this program, we also heard of the Houses of Healing program that was very helpful to someone else. Next slide, please.
Our final criminal justice sub-insight is that when people are re-entering their communities after incarceration, the transitions from criminal justice-based behavioral services to community-based behavioral health services are rather difficult. Quote, I was incarcerated for 7 years and took medication and saw a psychiatrist. Washington State Medicare would not accept documentation from Washington Correction Center for Women. The psychiatrist outside tried to prescribe me an antipsychotic that was not available at WCCW. I went down to Kaiser to get the medication, and Molina Healthcare and Washington State Healthcare would not give me the medication. 9 months into the process, I did everything I was supposed to do, and I was not given the medication that would have prevented a relapse. Next slide, please.
We've already had some conversation in the CRIS about emergency departments as non-ideal access points to the behavioral health crisis system. We hope that the 23-hour crisis centers will be a valuable alternative, but we still wanted to share some quotes from some stories about the difficulty of accessing adequate behavioral health care when presenting at emergency departments. Quote, they eventually called me back, took all of my clothes and possessions, put me on a stretcher in the hallway, and proceeded to leave me alone there with no sedatives or anything in the middle of the ED chaos while feeling suicidal. We know that long ED times are hard, period, but when you're in a behavioral health crisis, those long wait times can make things worse for people. Second quote, the student was held in the ER for about an hour. Then the actively suicidal child was discharged to the street with no notification to their parent, no safety plan, no care plan, no follow-up scheduled, and certainly no admission to inpatient. Next slide, please.
This is the first suggestion section. Suggestions throughout the presentation are based on what we read in these stories, but these suggestions are also reinforced in our lived experience subcommittee meetings over the last few years. Quote, a DCR was with the police and offered my son a mental health evaluation. My son declined. The DCR told me the arrest warrant for missing a hearing superseded her mental health evaluation. We're suggesting that we allow behavioral health intervention to take precedence over criminal justice, especially when there is an arrest warrant for non-violent crimes. Next slide, please.
Our second main insight is that there are multiple barriers to accessing behavioral health services before, during, and after a crisis. The CRIS has talked about some of them already, but some of them are new. Next slide, please.
This slide covers barriers related to insurance, cost of care, and transportation. First quote, my daughter has received a bill for $5,500 from Capital Medical Center ED. Next quote, I can't drive a violent kid nor drive in night nor safely transport. So in addition to quotes about transportation and getting bills, people talked about really a hard time finding providers who accept Medicare, Medicaid, and how out-of-pocket care is too expensive. Next slide, please.
The next sub-insight from these stories was a serious lack of resources, posing a huge challenge to accessing behavioral health services. First quote, no other teams or services for our remote area in Goldbar. Second quote, I wish we had drop-in centers or clinics where people could access mental health counselors to talk to. Third quote, in the year prior to him going into the CLIP facility, he spent probably almost 40 days sitting in Sacred Heart in their emergency room. People also talked about a lack of medication providers, detox beds, counselors, especially those with specialized skills like trauma counseling, and youth counselors. All of this leads to long wait times. There's a lack of one-on-one counseling in inpatient units, and there are staff shortages leading to poor patient experience. Some of these quotes resonated with what we heard from the rural and agricultural panel, the youth panel, and also much of what we heard today in our panel before lunch. Next slide, please.
Our third insight is that existing protocols are unaligned, inconsistent, confusing, and often do not meet the needs of the community. Protocols exist for a reason and might cover most people, but when they fail, it can have a very negative impact on the person and the community. Next slide, please.
Here are some examples of protocol hitches across the system. First quote, 911 literally would not come even when he was trying to kill me and himself because they were legally not allowed to restrain minors. Second quote, in the state of Washington, the only medications that can be legally compelled are antipsychotics. Mood stabilizers cannot. This is a real problem for someone who needs mood stabilizers to stay stable. Third quote, a nurse drew blood, not telling me why, and I was shocked to get the notification through my chart that they had done a tox screen looking for substance use. One thing that I know as a social worker in the system is that emergency departments run labs to rule out alternative causes for what appear to be mental health symptoms. For instance, psychosis caused by substance use or a medical condition, such as a UTI. They're doing these tests with the intention of getting the right care for patients, but if no one takes the time to explain that to a patient, it can be very upsetting. Fourth quote, I ran out of medication, had seizures for several months, almost died because nobody titrated me off any medication. Nobody had any ability to get me my medication again. When people change providers, They often need to meet with their new provider first and complete additional requirements before they will continue a prescription from a previous provider. People cannot always meet these requirements fast enough and may run out of medication during that transition, which can be a precursor to a crisis. Next slide, please.
These quotes speak specifically to challenges around DCRs and the ITA protocols. First quote, officer called me back, letting me know my son didn't qualify for an ITA under Ricky's law since he hadn't physically assaulted anyone in our home or committed a crime. Next quote. I was thinking he, crisis center social worker, would start the ITA process. He parked outside our house and then left without letting us know why. I called the crisis line back and I was told he felt unsafe going by himself, so he contacted Skagit County Sheriff's Office, asking them to come to the house. Next slide, please.
Here's our next set of suggestions. First, we need to educate the community about what each part of the system does and be transparent on what they can really expect. First quote, we ended up calling the police because we didn't know what else to do. This quote indicates we need to continue increasing awareness of 988. Second quote, crisis lines are 50-50. Often you just run out of time before you're de-escalated and feel abandoned when they hang up on you. This quote indicates that in addition to learning about 988, we need to educate people about what 988 does and what it is not. The community could be educated about the difference between crisis support and therapy, and that 988 does not have therapists for full sessions. Next slide, please.
Continuing our suggestions, standardize education for all service providers on how the system works in their domain and other related relevant domains. Let's consider this quote. Improve the ITA requirements gearing more towards prevention rather than someone having to commit a crime in order to be ITA'd. Our suggestion is to consider changing or improving protocols to better support the community. How effective are the ITA protocols in supporting the community as they are currently written? We really need to delve into this. Next slide, please.
The fourth insight is that the quality of support people receive across the continuum is inconsistent at best. Under this insight, we're highlighting both positive and negative experiences people had under each pillar. The proportion of positive versus negative experiences captures our sense of the ratio we saw across our stories. Again, this is not a representative sample. Next slide, please.
So for the someone to call pillar, it seems like a lot more folks are finding regional crisis lines or 988 helpful. This made us feel that the work being done on 988 call hubs is taking shape and going in a good direction. First quote, just talking to someone at a regional crisis line because I was very isolated and alone really helped a lot. Next quote, he, the crisis counselor, did tell me about Ricky's law, which we both felt was the best option. As we can see, it really helps when crisis counselors know the different programs and options across the system so they can better guide the caller. Right now, the knowledge is fragmented, it's not standardized, so the guidance will depend on how well the people on that shift know the system. It really needs to be standardized. Next quote, when I contacted 988 and they contacted the EMTs and police responded to my house. I'm very frightened by law enforcement and first responders. I asked them to please leave my house. One officer stepped aside and told me that they were also a veteran and wanted to help me. I did reach out after and spoke with them. Now, although this story ended with the caller making a positive connection to the responding officer, the caller should have been told what was going to happen. This quote also highlights the vital importance of educating first responders on how to interact with people in behavioral health crises. Additionally, we see that when the provider is able to disclose a shared identity, it can improve outcomes. And it supports the idea of diversity in workforce and peer involvement across the system. Next slide, please.
In the someone to come pillar, the ratio felt about 50-50 with regards to people's experience. Mostly, it felt when mobile crisis responded, people found it very helpful. The bigger issue was when they did not respond. First quote, they, Mobile Crisis, spent a long time listening to his story, and in the end, they gave him advice, which was to go voluntarily or be ITA'd. These two professionals were the best part of all the services. Second quote, I wish that the Mobile Crisis team had been more responsive to us and had actually come out to see her. Next slide, please.
This pillar of somewhere safe to go or be had the longest list of negative experiences. This area needs a lot of work to earn the trust of the community and encourage people to get the help they need. This is the pillar that will likely also take the most time. Quote, I would have never guessed that being diagnosed with schizophrenia and going to transitional resource would give me a future and save my life. Getting a diagnosis felt like a restart. Next quote. Inpatient was horrific caged animal experience. They threatened him with being sent to Easton in a straitjacket and told him he'd get ECT. Third quote. When she finally came home from inpatient, she said they did not help her in any way and she will never ask for help again as she felt she was in jail there. That last quote, it's important to see how one awful experience can change a person's relationship with treatment in devastating, sometimes even fatal ways. Next slide, please.
Our next insight is that bias may be playing a role people are getting. First quote, the system also ignored my suicidality because I am in a wheelchair. My problems were minimized and ignored because I am in a wheelchair. My PTSD was being aggravated but ignored because I am in a wheelchair. I was not hospitalized because I am in a wheelchair and unable to take care of myself and meet my ADL.
Next quote. They dismiss her because of her race or apparent drug use. She needed more workers familiar with trafficking. I wanted to let you all know that this person in the story died due to an overdose on the street. I cried when I read this story.
In addition, we heard about people being misgendered, treated poorly for being homeless or speaking with an accent, and about single fathers having fewer resources than single moms. Next slide, please.
So this quote captures the positive experience of good staffing. Harborview has the most doctors, beds, and because they pay the best, some of the best staff. Here are some of our suggestions on helping improve the quality of support people experience. Adequate pay and personal time off for the staff. Agencies be adequately staffed to minimize burnout. Training for staff on secondary trauma, on unconscious bias, on special needs, minority, underserved population care, on trauma-informed care, and most important, enable system users to rate the quality of care. Next slide, please.
Our fifth insight is that there are many gaps in collaboration between parts of the system and across systems. Next slide, please.
This sub-insight is that follow-up is not provided or adequate, and if they are told there will be follow-up, it doesn't come through. Quote, in the end, the youth was discharged with the PRN and no way to move forward or anyone to check in on him, his family in the following days, as it was a weekend. Next quote. 988 told me to call 911, which was a loop of numbers, having to answer questions, never getting anywhere, ending with asking if I want to answer a 4-question survey. Next slide, please.
The various parts of the system do not talk well to each other and people are falling through the cracks. Quote, with regards to gaps between services, there needs to be a service between WISE and CLIP. When WISE isn't enough, but the ER nor 911 are appropriate, where can a family get help?
So I think I said 911 in the previous slide. It's 211. I apologize. This next quote I can echo, having heard it from clients on the crisis line for 27 years. I don't know if the community providers we were working with just dropped the ball or if they didn't know either. And it seemed to us like everywhere we went, there was just kind of like this confusion on what the information was. Or the answer we got, oh, I'm not sure about resources. I have to check with this person. Then I'm going to have to double check with this other person. And it was always like a ball being passed from one person to the next until finally we had kind of reached a point where we had been struggling for so long. Next slide, please. Some suggestions from us. Let's start with the quote. Basically, I feel like there is support available, but it's too spread out between a million different organizations, and navigating this is a difficult process. Our suggestion is, if 988, someone to call Pillar, is going to be the hub, we really need to educate the crisis counselors and staff to know the system in depth, or at least be able to find the required standardized information in a centralized location, maybe on the 988 tech platform. Without this, forget the gaps in the system. Even parts of the system that are available are not accessible. Next slide, please.
Our sixth insight is that follow-up and prevention must be added as a pillar in our system. We need to blur the lines between crisis, postvention, and prevention. To think of one without the other is a disservice to the whole human. Next slide, please.
This sub-insight is that without follow-up and prevention measures in place, people keep cycling in and out of behavioral health crisis response. Quote, where are the peer support counselors? Where are the people that link my ability to stay stable and well? Next quote. Ensuring seamless transition to ongoing care and support beyond the initial crisis. I hope they integrate substance use crisis response with long-term recovery resources. Third quote. After 3 months at a long-term facility, Teleka in Shelton, he was released to a homeless shelter in the University District. He was arrested 6 hours later after smoking something, taking off all his clothes and dancing in the street nude. It was clear he was not stable when he was released, even though he was at this place for 3 months. This is utterly stupid. Releasing someone as mentally ill as my son to a homeless shelter in the University District is negligent care. Next slide, please.
Additionally, the lack of basic needs being met can trigger behavioral health crises. First quote, housing was another issue though, and while everyone else seemed to get free housing after a time, I could never figure out how. The issue was that they were always reward-based or contingent on sobriety, completion of a drug treatment. You could get something like housing, but you had to be clean and stay that way. There were too many hoops to jump through for basic necessities, so eventually I gave up trying. I was on the streets of Seattle battling drug addiction and homelessness. Second quote, it is common for the closest family members to cut off all contact and withhold any money or direct support once there's a serious crisis. What follows are years of difficulty getting health care, dental care, food assistance from the state, etc. If we want the crisis response system to work well, we must focus on the prevention system too. Going through repeated cycles of crisis is not good for people, their loved ones, or the community. We think it is also a more expensive way to fund the system. Just like having a heart attack and requiring medical care or surgery is more expensive than education and support around heart health. Next slide, please.
Our seventh and last overall insight is that natural supports are an untapped resource and need to be an integral part of the design and delivery of crisis response. Natural supports are defined as the unpaid relationships and associations people have in their everyday lives that improve their quality of life. Next slide, please.
There is a need to strike a balance between personal agency and family engagement. We had families say, quote, another weakness is that there is little family involvement with a treatment plan. But families also reported, quote, Harborview, someone on John's team called me and asked for his history and the circumstances of this particular hospitalization. Almost no other mental health facility does this. Sometimes I wait over a week or two before the social worker calls me. Families also touched on the issue of anosognosia, which is a term for when someone is not aware that they have a mental health condition. Quote, she would go to treatment, do better, get out, and relapse. That was a repeated cycle. She was clearly not able to make informed decisions. She continued to check herself out of rehab every time we got her into a substance use or mental health facility. If we had a way to make her stay in treatment until she was stabilized on medication and in the right frame of mind, I feel like this could have prevented. On the other side of this, though, we have quotes from people talking about how their family can be a source of stress or even trauma. Fourth quote, I have had to overcome serious trauma from childhood situations and instances. When natural supports are positive, they can be very beneficial to the person dealing with the behavioral health issues, and as such need to be part of the treatment plan. But we need to recognize that people calling themselves a natural support could also be a source of stress or trauma. This balance or tension between what the family wants and what the individual in crisis wants is something we haven't really delved into in the CRIS, but it's a theme that has come up consistently over the past 3 years in the lived experience subcommittee meetings and in the story project. Finding the right balance will need serious engagement and discussion. Next slide, please.
So people who support people in crisis themselves struggle or can also be in crisis and need support. Here are 2 quotes. Quote, when there is physical violence beyond the ability of a parent to handle, who can physically come? Literally, no one could help during attacks. He had the legal right to kill me. I'm disabled and lived alone with him. Restraining him requires 3 people. He broke down doors to attack me. I had no safe place. Next quote, and this was submitted by a person calling for help for their ex. I would have benefited from mental health and support systems for myself in managing my codependency and trauma. I could have used some support to get connected with CODA, peer support groups, a counselor, information on codependency, and how to handle situations of emotional abuse. Next slide, please.
Borrowing a quote from Reverend Martin Luther King Jr., here's a verbatim dream from a mom on ideal care for her son and family. Next slide, please.
I want a place for my son that doesn't exist, but if it did, it would have doctors who listen, not over-medicate. It would have treatments like individual therapy. It would have a nice room with soundproofing so he would not be bothered by screaming of others. It would have wonderful, healthy brain healing food, not the cheapest slop. He would have access to the outside. It would provide a step-like system that he would gradually be reintroduced to the real world, like a single room in a locked ward, to a room in an unlocked ward at night, to a studio apartment with medication management. This mythical place would be close enough so his family could visit, and he could do things he wants, like re-enter community college. Always get goosebumps when I read that. Next slide, please.
Please know to each of you who have supported this Stories project, we offer our heartfelt gratitude. Next slide, please.
Yay, we made it. Thanks for listening to us. Here is a summary of our overall insights. We'd love to hear what you thought, what stuck with you, what you felt, any ideas you have to share with all of us, just as a CRIS discussion. And Michael Anderson, AP, who is there in person from HMA, who read the scripts and coded them with us, will join us for this segment. Thank you.
Tremendous work. I only got a small window into how much they were working. They were working so hard to pull this together for all of you. So really big thank you to Kristen and big Marsha for all of your work. And now I think it's time to dive into your questions, Kristen. This is a time for you to ask questions if you have any clarifying questions or if you have any reflections on what you just heard. And maybe to see your thinking, I'm curious if anything you heard today surprised you. I mean, I certainly heard a lot of consistency with what we've been talking about over the last 3 years. I'm curious if anything stood out as new information or surprised to anyone. Let me check and see if we have any hands up. Any questions or reflections? Amber.
Hey, well, let me start by saying, yes, you got a big round of applause here, and thank you for all the work that you put in putting this together. It really was amazing and informative. I had a question. When you were looking, one of the pieces you talked about, I think it was under quality of support, it talked about safe place to go. And I heard you all that that's one of those spaces that had pretty significant negative comments. But I was curious, did you see anything across those answers in terms of where people went in terms of a safe place to go, making any difference in terms of positive or negative experience, or was it more about general access compared to not having access? I was just curious if there was any breakdown in that topic.
Definitely. We, for a safe place to go or be, we got responses about emergency departments, inpatient facilities, and a few about crisis diversion services. We did have some positive quotes for most of them, but in all cases, overwhelmingly, the quotes about a safe place to be or a safe place to go were the most negative across everything we read. It sounds like people are having a very challenging time in general, figuring out where to go to have a positive experience in a crisis.
I mean, and also I just wanted to say that we can, you know, these stories have been submitted. We can always go back with the resources and recode to see what specifically people mentioned so that we get a better, more fleshed out picture of what's happening under that pillar. Just a thought.
I have a hand up on Zoom from Senator Dingrad. Senator Dingrad.
Thank you so much. I actually have no words to express how amazing your guys' presentation was. I love the way it was structured. I liked how concrete it was. I love the recommendations. It's a little overwhelming, to tell you the truth. But I had a couple of questions, and this is not necessarily for the lived experience committee. You can answer it, but even for the other partners that I hear, there's a couple of things that stood out to me when you talked about insurance being a barrier, and I would really like to understand more. Is it having the lack of insurance, or was it the type of insurance? Because a lot of the work that we've been trying to do is around making sure that there is parity in insurance coverage, that they cover mental health just the way they cover physical health. And I think we have the right people in the room to maybe have that discussion on what else do we need to do in order to make sure that insurance does the coverage that's needed, assuming it is a type of insurance and not just they don't have any insurance. And then just a connected one to that was also the filling of the prescriptions. We have done, well, I guess IPRIME sponsored a couple of bills that really is trying to remove those barriers and making sure that the medications that doctors prescribe are the ones that are covered. And so I would love to hear more to see what's going on with our insurance or with healthcare. I don't know if we had a delay on that implementation. The other thing we had done, and I think this may apply only to jails and not our prisons, and so we should have a conversations about prisons, but our jails are now required to fulfill mental health prescriptions in the manner they're prescribed and not do substitutes. And I wonder if we need to do something like that for our prisons as well, because it is always a concern when mental health prescriptions aren't covered specifically as prescribed. And I do believe that bill that I had a couple of years ago did require our prisons to cover them and make sure that Medicare, that our government programs don't substitute other meds when it's related to a severe mental health issue. And I have a couple other questions, but I want to stop at the healthcare prescribed medication and see if anyone else has any comments on that.
I just asked for the demographic slide with insurance to be put up in chat. So we'll see if we can get that one up. I know from memory that most of the people who responded did have insurance. So based on that, my suspicion is going to be that it's about the type of insurance and how many providers are available under that type of insurance. Okay, we've got it up here. So only 5% of people who responded are uninsured. We had 39% with Medicaid, 37% with private insurance, and 19% with Medicare. So that suggests that the problem is about how insurance is covering things, not about a lack of access to insurance. The questions about medication, I can't remember I don't believe the person from that story specifically mentioned what medication they're on, but I do know that for some medications that are controlled substances, there can be a lot of extra requirements. At the agency I work at, I know, for instance, that to get a prescription for ADHD, those controlled substances often require multiple drug tests, multiple weeks in a row to show that the symptoms they're experiencing aren't based on substances. And as many people with ADHD might be able to tell you, remembering to do that multiple weeks in a row when you don't have your medication might be very difficult.
It's humanizing.
But was just like dehumanizing also.
Yes. It can be very hard for people that say, like, I've been on this medication my whole life, and to be told that, well, we have to do our own checks to make sure that you should be on it. It's very challenging. And let me see if I can remember, what was the third question? Oh, the jail system. That one was you, Bipasha. That's your story, so I'll let you talk.
I just also wanted to say, and Kristen and Michael, please check me. I think the Medicaid and Medicare were the most names that came up in our stories, not so much named. But I do want to say, yesterday I read an article on NPR about ghost systems in private insurance, where people are seeking insurance. It looks like they have a lot of coverage for mental health, but when they start calling the people, they don't hear back because insurance companies are not cleaning out the list of providers they have as a way of inflating the image that they have more providers than they have. And I'll be happy to share the link to that particular article that I read, and so if Jamie wants to share that. I think in terms of the criminal justice system, the couple stories that I read were, I think it was not so much the jails, but the prisons. And I think we tried to capture a piece, but it felt there were stories about people who went back and forth. So they came out and then they didn't get the help. They tried to call, then they went back. So it's this, when they're in the criminal justice system, the medication management and all that is different, and it's not very even. So what they're getting inside, and I didn't know this, but I didn't realize that there were certain classes of drugs that DOC will not prescribe. So when they come out, they're not used to that. So now they have to figure that out. And then in that quote, we mentioned Medicaid, I think, where Medicaid would not meet the antipsychotic that was prescribed. So yeah, that's what I Michael, if you remember anything more, you read all the stories too, please add.
Michael doesn't have anything to add, he's shaking his head, he doesn't have anything to add. I see Dr. Snowden might be able to jump in. Dr. Snowden?
Thanks. I wanted to second what Senator Davis said about how beautiful the presentation was. You guys did a wonderful job. To your question, the part I can add about the medications is for certain newer medications, particularly long-acting antipsychotics, it's not that it's not going to be covered, but it requires a repeat authorization. So you can get it authorized in the hospital, but when that same patient is transitioning to outpatient, the outpatient providers also have to now reapply for authorization. And that process can take weeks, meaning that there's a significant risk that the person is going to run out of the medications that were provided at discharge from the hospital before the outpatient provider has received the authorization to continue the medication.
Can I actually ask a clarifying question? Because I think the bill that I did 2 years ago, the whole intent was that you don't have to get authorization for severe mental illness prescriptions once they have been prescribed. Why would that Bill. I wish.
Okay,
Covered
unless
the
like
scenario.
James could be able to help us with that one.
I'm just so glad Jane is here. That's all I want to say to everyone, because I feel all my questions were directed towards Jane, but I didn't want to call her out, but I will now.
That's cool, that's totally fine. So Senator, 5300 goes into effect January 1, 2025. And I can say that one of the questions that's come up from the health insurers is, how do they know that a drug's been prescribed for an SMI because serious mental illness, because of how much off-label prescribing there is? So they're should be putting their heads to how they're gonna review those prescriptions. But it does come into effect January 1, 2025. We're doing rulemaking on it right now. And we always say that if folks encounter challenges and their plan is trying to switch them to another drug, then we need to know and call us with a complaint. The issue that comes up is most of the health insurers contract with pharmacy benefit managers to manage their prescription drug benefits, and those formularies change too often. And your bill is right? We need to keep people stable on meds that are working. So that's that. I listened to the ProPublica story in Pasha also on Ghost Networks. Ghost Networks, Congress has done hearings about Ghost Networks for Medicare Advantage plans. We have really extensive network adequacy requirements, and the issue that comes up is not only the accuracy of an insurer's provider directory, but also the fact that an insurer can get a bunch of contracts with providers, but there's nothing that obligates the provider to see every enrollee for that health plan. It would probably be physically impossible for them to do that because they wouldn't have room in their practice. So it is an issue of, I think, looking at things like prior authorization, looking at things like credentialing, looking at things like the amount that behavioral health providers are paid for professional services, to try to figure out how we can have, especially the private therapists who are out there, number one, more willing to contract with health plans, and number two, when they do have a contract, being more willing to see the enrollees for that health plan. And we do oversee the accuracy of provider network directories. We are going to be enforcing 5300, but a lot of that is we need to hear from people when they encounter issues.
Thanks for jumping in there, Jane. I want to take us to another question. Senator Warnick has her hand up. Senator Warnick.
Thank you. And I want to add my appreciation for a very good presentation. My question has to do with a young person, probably teenager or younger, being released from an emergency room or released from care. And I didn't write down which one that was, but did you hear that happening very often? And are there suggestions to avoid a child being released and ending up in a homeless camp and being targeted? Because I've heard this before. And is there a recommendation that you might have after speaking with those folks? How we can prevent a child being released from an emergency room or other care without a parent or a guardian knowing that?
Yeah, so this is something that came up quite a few times in our stories. We kept that one specifically because it was a youth, and we know from the youth panel that there are not enough youth services. So one of the suggestions would be to increase the amount of youth services available so that there is somewhere for them to send that youth, for them to go after the emergency room. But one of our insights related to emergency departments that we didn't spend a lot of time on is that people are often feel like they go to an emergency department and then are discharged from that emergency department without any real behavioral health intervention taking place, which is not surprising. We know from a lot of conversations about emergency departments that they are not an ideal location to get behavioral health care. People go there because there's not a lot of options. And like we said, we're hoping the 23-hour centers are a better alternative once those open. So, so they can get some treatment from somewhere that's more modeled towards behavioral health rather than emergency physical health situations. This also goes into a conversation about natural supports, though. Especially with teenagers, there's a lot of conflict between the agency of the youth, because once they turn 13, they have a right to access and use services without consent of their parents, but also that the parents are responsible for this youth. And so they generally want to be involved. They want to know what's happening. And I don't know that we have an answer for that. This is something that's talked about a lot in our subcommittee, because when there's a solid family foundation, they can be a very good natural support for that youth. But we also have to recognize that sometimes a youth's family are not positive natural supports. They are a source of trauma and stress, and that's why the youth doesn't want them involved. I don't know, Patasha, do you have anything to add there?
I just wanted to reflect a couple things. Joan, you said we need to hear from people if they're running into these, ghost network issues. And also, Senator Warnick, you asked if we talked to these people. So this was a story submission project just by writing or submitting we had initially envisioned this project as a two-step process, which is doing this as the first round, and then being able to actually do the interviewing with the people to go more in depth into what happened. And unfortunately, because, the CRIS process is sort of the way it's being run is ending. And so our request is to see if HCA or whoever takes it on, or and it doesn't have to be under CRIS, but is there a way to provide people to be able to give direct input about their experience to the state? I think that's what's coming up from both what you all said, and how can we follow through? We've tried that through the CRIS's lived experience subcommittee, which has been an amazing opportunity for the community, but just a thought, putting it out there for whoever has the power to figure out how do we keep this going on in perpetuity, not under the CRIS necessarily, but we need a space where people can really give direct feedback to the state on what they're experiencing in the system.
And thank you for that. And I don't mean to say that the emergency rooms are not the place for some of these treatments. I think they do amazing work in most emergency rooms, and they just can't do it all. So we just have to be able to support the people that's the only place they have at this point. So thank you. It was a very good presentation.
Thank you. And I think I just want to, we did mention the 23 hours drop-in groups. As they, expand across the state, they will take that pressure off the emergency department and people will get more tailored care over there.
Yeah. Very good.
So we have a very short time left. I see hands from Puck and from Dylan, and then we're probably gonna have to go to our break. So let me bring it over to Puck, and then Dylan, I'll come to you after that.
Yeah, I wanted to thank you both for so much work that you put into this, and also just to speak a little to the limitations of this project. This camp came up after we brought several experiences to the CRIS, and we kept hearing responses of like, oh my God, that's so terrible. And the stories that we brought, like as lived experience people, we've heard and seen over and over and over again. So we wanted a chance to highlight the fact that no, these aren't individual terrible experiences. They are happening regularly. And we were able to get a fair bit of feedback by providing some financial compensation for this. So we weren't just asking people to tell us about it because they cared and had hope for the system. but there's still a really huge lack in this, in that basically, like, we're not getting to the people who have been most failed. We're getting only to the people who are still able to advocate for themselves or have people who are caring for them. And without doing some very intentional on the ground work to speak with the folks who are still in crisis, which is almost impossible, this is still a really shiny, good picture that we're seeing here.
I also want to acknowledge that that is a theme that you have brought up to us in many conversations, and I want to honor that you raised that to this committee. I'm going to bring this over to Dylan now.
Hi, thank you. Dylan Ishmael, the Ethno Program Patient Health and Referral Service. For folks that are from the county, we have a process for the coordination of care, a notification system for providers to talk about the transition of care following hospitalization and other types of care, which it is specific for providers, but I love the lived experience feedback process as well. If there was a way to get multiple angles of the story of what went wrong and what could be done better, and to see any failures in process and protocol, we'll be able to see that as well.
So, Bipasha and Kristen, I'm hearing some echoes of your call to have opportunity to do more in-depth work on this. So, Kristen, do you want to throw something in?
Yeah, like Puck said, we didn't get to do the whole project as we envisioned it. One of our motivations for this project was that we had a person in our lived experience subcommittee describe a situation that happened, and then between us with our lived experience and the different agency staff in the room, we were able to figure out exactly what happened and why it happened by having a conversation, so we could know what the solution was. So we really wanted to have the opportunity to interview these people more in depth after hearing their stories, so we could kind of go through that process on some individual stories and get more detailed information about why their story happened the way it did, not just what happened. And it's hard. It would require a lot of outreach. It would require a lot of work, but we feel very passionately that moment in our subcommittee where we were able to actually state, here is what happened, here is why it happened, here's how we fix it, was only possible because we engaged with a person about their story of their experience in the system.
I'll just add a little more detail. Kristen, I think you're referring to the point where people were transferred 4 times before they talked to someone. And I think between DOH and HCA, we figured out that they had gotten bounced to Vibrant instead of within state. And that was also addressed by that decision, which I love, that in Washington State, if one of the hubs cannot answer the call, it will float to the next hub within Washington State, which is better than it going to this centralized place somewhere on the East Coast where people really don't know the state and the area. So that was what Kristen was referring to, and that was very helpful for both the client and I think for the system.
Michael has one thing to add, and then I want to read a comment that Kashi just sent so that everyone can hear it, and then we're going to go to break.
Yeah, hi all, Michael Anderson, AP, he, him, his pronouns. I had the honor of working with Bipasha and Kristen on this analysis and coding, and I read all the stories. And, you know, this is a ton of work to get distilled down here, but I will say as someone who read every story and all the words, there is so much information in those stories. And you really have like 1 or 2 quotes underneath some of the insights, but there are many quotes, and like one story often touches on many of these insights, right? So there's a lot of richness in these stories. It was very hard to read all these stories, so kudos to Kristen and Bipasha for sticking through it and for putting this together. But there's a lot of rich information if we just listen to those who are accessing services. And I just wanted to lift that.
Thank you, Michael, and I think this is a perfect closing comment for Kashi. Thank you so much for this work. These are incredibly resonant. It is really important and powerful to hear these stories and to be accountable as a system to be doing better. So thank you for that. And I apologize, I should have mentioned this before I went into the discussion. Luckily, I think
we all did a pretty good job with it, which is our ASL interpreters are working very hard to keep up with our conversation. And so the more that we can slow down, which is one of my personal challenges, and enunciate, the easier we will make their very hard job. But I think this last discussion went pretty well, so thanks everyone. With that, I just want to give a huge echo to all of the compliments and appreciation that has been shared here for this work that Natasha and Kristen have done to pull this together. And of course, Michael Anderson, Nathan, tremendous work. I think this has been really informative, and I think we'll be really make our discussion this afternoon about our recommendations all the richer. So, oh, and Christine Milana, thank you. Yes, anyone else?
No, but Christine below.
Okay, and Christine did a lot of work too. Christine's on today, so Christine, a big thank you too. We're gonna take a 10-minute break. Actually, we give you a bonus 2 minutes, so we'll take a 12-minute break. Let's be back here on camera at 2:15, and we're gonna start our afternoon discussion. I'm going to wrap up your conversations around our table. Please. Thank you, everyone. Okay. So we're going to start the next portion of our agenda. This is actually when we are going to reflect on, and I guess refine is probably the right word, but we solidify our recommendations that we want to consider final, that we put in that report. You're back online with her. Oh, let's take down the break slide. Can we take down the break slide, please? Thank you. This is as you know, we have a final CRIS Committee report that's going into the Governor's Office and Legislature at the end, or the very, very beginning of 2025. And this is our opportunity to go through all of the recommendations that we have generated as a committee in our 3+ years together and make some decisions about what goes in that final report. So I have an exercise for everyone to lead into our discussion, and I'm going to have 2 sets of instructions, one for folks in the room and a separate set of instructions for our CRIS Committee members who are participating by Zoom. So for folks in the room, you will see at the back of the room, we have printed poster boards. These have all of the recommendations you've worked on over the last 3+ years, synthesized and put onto boards here. And in front of you, you will find some post-it notes. For CRIS Committee members who are participating by Zoom, we've created a virtual version of this that I will put up momentarily on a Zoom whiteboard. So what I'm going to ask everybody to do is to, in the room, you want to get up and go to the back of the room. I want you to spend some time refreshing your memory on these recommendations. Read through them. Take your sticky notes with you. There's some pens at the back and some extra sticky notes as well. And think about your reflections on these. And I'm giving you a lot of latitude here in terms of how you reflect on these. Just a few things to consider are what stands out as a high priority to you. So after all of this last year of learning about people with substance use disorder, crisis response for youth, for rural and agricultural communities and populations, for tribes, and today for people with intellectual and or developmental disabilities, what you just learned from the Lived Experience Stories Project and all of the stories we've heard in the last few years. Think about that and think about what really stands out as a high priority for you. That's one thing you can think about in your reflections. Another is, are there any adjustments that we need to make, modifications that we need to make to these recommendations based on all we've learned? And then we'll have a discussion after that. So what I'm asking you to do is take those sticky notes and just write individual reflections down, stick them up on the appropriate board. I know it's gonna look messy and that's okay. And then folks on Zoom, as I dismiss the folks in here to go do that exercise, I'll get on Zoom and show you how to do it on the whiteboard. And we're gonna take about 20 minutes to do that, to do our own reflections. And then we're gonna take some time to go around and read what each other has said. And also read what we see on the Zoom board. I also have, not to overcomplicate things, but I also have some dots here. So if you read a reflection from a colleague that you think, yeah, that I agree with that. That's pretty important. You can use a dot to signal that. You don't have to rewrite the same reflection. You can just use a dot. And I'll ask Michael to distribute dots. Okay, so that's going to be, let's say, it's 2:20, so let's take the next 20 minutes. We'll go until 2:40. I'm gonna give the folks on Zoom the instructions too, but everybody, you can feel free to get up and go to that. Michael, did you have a question? Okay, all right, so go up and go start writing your reflections. Betsy and Michael will be available to answer any questions if you have any confusion or concerns. And I'm gonna hop on Zoom here with my Zoom folks. That's what you do.
Okay, everyone, can you hear me?
Yes, we can.
Okay, I'm going to share my whiteboard. All right, should be loading. There we go. Okay. So first, I just want to emphasize this, community members and guests, I, of course, love hearing from you. Today, I'm just going to ask that CRIS committee members add reflections. I'm going to ask community members not to add any sticky notes to the board today. So CRIS committee members, you should be able to zoom in and zoom out to the board so you can read all of the comments. And then if you would like to add a sticky note, I'm just going to show you how you do that. On the left-hand side of your screen, there should be a toolbar. And you want to highlight, it looks like it's the 7th item down. It says sticky note. Choose a sticky note, and then you can just drag it over and type into it. And you can place it, you can move it around and place it wherever you want on the board. And then if you also want to comment on someone, not comment, but add a appreciation or an agreement with someone's, you can click on their sticky note and it pops up a little toolbar. You can click on add emoji and give it a thumbs up. And that will show us that you're agreeing with or you share that reflection. So I'm going to delete my comments. Any questions about how to do this? I'm going to go ahead and copy and paste the instructions I gave in the room into the chat so that you can remember what we need to do. And we're going to take the next 20 minutes. So we'll go to 2:40, but just take your time, go through and offer your reflections. And again, this is just for CRIS committee members. I'm going to ask community members on the call if you can just observe right now.
Hey, Jamie, can I ask a question?
Please.
Does this, these columns, do they map to what we got in the recommendation summary draft?
Yes, they map exactly, and they're exactly what we're looking at in the room as well.
Thank you.
And I have a question. Do I need to sign in to be able to do this?
That's a great question, Senator Warnick. Do you have a Zoom account?
Well, I'm on the Zoom account, but see, on top of it, it says sign in.
Oh,
You don't need to, Judy.
oh, okay. It's working fine without. Okay. Thank you for testing that for me, Senator Dinger.
Yeah. Okay.
Any other questions? Okay, I'll be on here to help out if you run into any jams or have a question.
All right.
And just so you know, folks, I might be going in and resizing some of your sticky notes to make it easier for people to read. So I promise I won't change any of your language or move it away. I'm just going to adjust it so everybody can read it.
Jamie, I'm guessing you were talking to others and not us online. I saw your lips moving.
Okay, so CRIS committee members on Zoom. I've asked people in the room here to start going around and reading each other's reflections. I realize that you are not able to see what they have written, but when we get to our discussion, I'll make sure that we uplift some of the key themes from what they're saying. And we'll also make sure you get to see a summary of what came out of this. So don't worry, you're not being left out. But please just use the next few minutes to read the reflection. You can continue to work on adding reflections here and also use time to read each other's reflections and amplify them with an emoji if you like. We're going to take probably another 10 minutes here and then I'll bring us to discussion.
Okay, I'm gonna ask everyone to wrap up and come back to the table so we can start our discussion. So now what we need to do is kind of marry what our people on Zoom have been working on and our people in the room have been working on. And for that, I'm going to rely on everyone to help share information. So folks on Zoom, I'm going to cue this up for you. I'm actually going to ask, because we actually tried to show your Zoom board in the room and invite people to come read it, but it's really hard to read on our end. So I'm going to actually ask you, if you could all take a look at what your colleagues said, I'm going to ask you to think about what are some key themes that have surfaced for you? Is there anything that stood out from what you and your colleagues said on the Zoom board? And I'm going to ask folks in the room to share the same information back to you about what they're seeing in the room. So, everybody think about that for a minute. If you went around and looked and saw what your colleagues had written. Is there anyone on the Zoom, is there anyone on the Zoom who can share with us some interesting or common themes that they're seeing on the Zoom board?
I'll jump in real quick.
Oh, you know what? Hold on a second, Senator Warnick. We're either not hearing me there with it. Just a moment. All right, go ahead. Sorry about that, Senator Warnick.
Yeah, okay. Still having a hard time understanding or hearing. I commented on cases where we were looking at rural areas, the need for training, especially for agricultural families to understand the cases of maybe suicidal tendencies and mental health tendencies. And then I just had the one comment about the 211. I had a comment or a conversation with folks from 211. I think we need better coordination between the 988 and the 211 folks, because some of the questions could be answered through 211, but not necessarily if a person's in crisis. So we maybe need some better coordination, better training between those two entities.
Senator Warnick, I believe that comment was echoed a couple of times on the boards in here. When I was going through, I saw that very comment. So I think you have some agreeers in the room. And I want to go back to your first comment that you made, because I'm not sure I was following. Would you mind just telling us which recommendation you were talking about with your first comment?
Number 5, on the first column, staffing, training, workforce. Number 5 in that column.
Oh, yes.
Okay. Just to better understand rural people, agricultural people, because we have everyone from farmers to farm workers to businesses and families, so that are impacted. There's a higher rate of suicide among agricultural workers and agricultural entities. That's what I just learned that. And so if we could have better training.
And for those of you who can't read the board from the room, it's the particular recommendation that Senator Warnick's talking about is the one about expanding mental health first aid training for lay people. And yes, Senator Warnick is reminding us of a really important thing we learned in the rural agricultural panel last April, which is that farmers and agricultural workers do have the highest rates of suicide. And have very different needs from other populations in terms of crisis response. So thanks for raising that, Senator Warnick. Other folks on Zoom, can you help our people in the room learn a little bit more about what were some key themes from the work you did here?
Yeah, I saw a lot of notes about prevention and postvention, the need for us to really put a focus on both prevention and postvention to to manage the amount of crisis that we're seeing in the state.
Kristen, thanks for raising that. That was actually, one I saw when I was reviewing. I noticed that on the prevention board, there were a lot of reflections there and a lot of dots of people echoing that prevention is actually the most cost-effective and least trauma-imposing way of addressing behavioral health crisis response. Anything else that you noticed, Kristen?
The other one I think I remember seeing multiple stickies about across the board was about incentivizing providers, paying providers well, just generally finding ways to increase the number of providers available across the system, but especially in rural areas.
Yeah, I saw that one a lot too. How about in the room here? Can we help out our Zoom folks who can't see the comments we made? Anyone in the room, did anything stand out for you when you were going through and looking at your colleagues' reflections or comments?
I saw a lot of things, okay. I saw a lot of things across the different boards about prevention, about how we need to have a more robust social safety net in general. About, I think I saw on 3 different boards that we need to make sure that 211 has the support and funding to keep people from becoming in crisis. And I think that's something we've been saying this whole time, that we can't just do crisis here.
I saw that out too. Thanks for calling that out. And it was also mentioned in this exam. Yes, Michelle.
Yeah, I'll just echo that. I saw that theme too, and a lot about where are we investing in upstream community resources, more broadly for social services, social determinants of health, consistency in resources that families are getting to places like schools and stuff, which can depend on right now, like where you live and what's going on. So I think there was a lot around what that upstream prevention could look like.
I'm also thinking about workforce, that I think there's a lack of people that are willing or wanting to go into crisis work. And then also just accessibility for services that are outside of regular work hours and outside of like even in the school setting. So after weekend hours and after school hours, after work hours is just not as readily available because not everyone has the flexibility to step away from the work, such as our rural worker, agricultural workers, and other folks that are maybe just don't have the same office flexibility.
Thanks, Dylan. Tori.
Another thing I saw, just different ways of, I think, describing it, but really driving towards a more co-occurring, capable system of care and not looking at someone, oh, you have substance use disorder only, or you have mental health. Really that whole person, looking at the totality of the person and making sure that we have workforce and services that are able to accommodate that.
And Tori, you noticed when I was looking at what folks were putting up on the Zoom, that they reflected on that story of the veteran who was fearful of law enforcement, but then discovered that one of them was also a veteran, and that changed the moment for that person. And so and I see this across here, how important it is. And also everything we've learned this past year, I know Tori just joined us, but everything we've learned this past year about the needs of different populations and how so many of these identities intersect in one person and they need multiple supports. So, Darcy.
I didn't put this up here, but as I'm listening to the conversation, I'm reflecting that the conversations about prevention upstream, 100% agree with. Historically, I'm old enough to know we've had these conversations for a really long time, and often in the thought of zero-sum game, it's often like you either prevent things or you take care of the crisis. And for us to recognize that both are equally important, and we can't take from one to try to make something else better, or we won't have either working very well.
Isn't that the big struggle too, right? I'm going to turn back to Zoom to see if anyone else in Zoom has a reflection they can share from the work you've done here on the Zoom board. I also noticed, I'll just say a reflection from when I was looking at the Zoom board, I noticed there were several stickies up here related to the recommendation about having an ongoing mechanism for system users to be able to provide feedback, and that was indicated as very important and certainly a big outcome from the lived experience project. And I will tell you, when Nicola and I were working on synthesizing all these recommendations, that really stood out for me as something that was very important to this committee throughout this year.
I think one of the things that stands out to me even looking at these posters is how many Post-it notes are on the services board and how necessary that connection to the next step in care is from the crisis response system. And a lot of what's reflected on the service, both the service board and the staffing training workforce board, is that those are places where there are still real deficits, and that the crisis response system is in some ways interdependent on what it can connect people to. And so how do we continue to invest in this crisis response system and the workforce and the people who are taking calls, knowing that part of their role is navigating a system that doesn't have everything we need yet for the population.
So that nicely leads to another question I wanted to ask you that I think will help us draft this report, which is, we've done a lot of work together in the last 3.5 years, covered a lot of ground. And hopefully you're feeling proud of what you've done, seeing all of this work that you put up here. And you'll note in the, Jane and I were just talking about this at the break, you'll note in the report, you'll see that a big part of that will be showing what action has been taken, what has been done to date on many of these recommendations. But we're all acknowledging there's still a lot of work to do. And so my next question for you, and then to service even what we're talking about regarding services and also prevention, is what are some, we don't want to get into any new recommendations today, but what are some gap areas that remain, places where you feel like work still needs to be done to analyze what's needed and make recommendations? And after looking at this, what are some gap areas you're seeing? Look at Dr. Snowden.
Thanks. I didn't put it up there, but I can't tell you how happy I was to see that somebody actually on the board behind this wrote that we have really not talked a lot about geriatric patients and families. And so I think that's still a huge gap area.
No, I'm glad you brought that up because I remember seeing that note thinking, yeah, that's right, I'm not. Checking to see if we have any hands up on Zoom. And I got, oh.
I think a big thing that's come up as we've talked about the bill of rights stuff, and some of the bad experiences people have had, has been patient agency. And I feel like there are a lot of experiences people have where, because they are dealing with a mental health crisis, they are removed of their agency. And I think that that's a really challenging thing, because returning yourself to your mental health involves claiming your own agency. And so I think that that's a really challenging thing that fits in with the oversight piece of it.
So I'm gonna ask you to say a little bit more about that part to make sure I'm understanding. So patient agency, meaning that sometimes or often it feels like things are being done to the person rather than in partnership with the person?
Yeah, in Arizona, the Arizona model works based on the fact that it is illegal to be in a psych episode, and so they are then immediately able to medicate people. And that's not how it works hypothetically in Washington, right? And so, yeah, I think it's just, we have really vulnerable populations and we need to make sure that we're keeping them safe as we try to help them.
Okay. That's my that's not the time I use for my morning alarm, so.
Thank you. Around patient agency, I saw someone put up there around psychiatric revenge directives. And I think that's maybe something we could look look more at, and I know we have crisis plans under point click care and other things, but I think getting other providers to actually look at it and actually use them and honor them when they're available.
Okay, so more work on how we get psych and advanced directives to be, more common, more used, more.
And honored.
And honored, yes. Alicia?
I think part of that is also building understanding of when people are interacting with traditional first responders, what expectations they have, because I think that sometimes there's a lack of understanding of what the protocols and procedures are when people are engaging with traditional first responders and coming into a fire agency that I hadn't ever had engagement with. They have a whole set of protocols and they have state protocols, but then each county has their own medical director that manages their emergency medical services protocol. So those can vary from region to region as well. And so I just think as we talk about building knowledge and understanding when people are in crisis, it's training people who are supporting people in crisis, as well as allowing the community who might be in crisis to understand what they can expect when they're engaging with different providers who might be serving them.
And Alicia, let's pause on this one too, because one of the things that I've heard from many of you over this year is that it's important both to have some statewide consistency and ability to tailor things to regional conditions. I think particularly for rural areas. But there's also been a tension that I've heard from all of you that can also create a lot of complexity for people understanding what to expect, also understanding how to deliver services. So I hear what you're saying, and in the spirit of the question of what else needs work. Is it navigating that particular tension that needs work? What are your thoughts there?
I think it's important that there's a general guideline and then also that every county or space is able to work with what they have. And so I think it is developing balance and understanding based on the area, because just to say this is what everybody's gonna do from now on isn't gonna be effective and somebody's always gonna be missing out. So there is a need to create balance. And I think if you're not putting out information so people don't know, then that I think adds to the tension, because when they're moving from county to county, especially my programs in Pierce County, King County is not very far, and you can go to Edgewood and go to Pierce County and then go across the street and now you're in King County and Auburn. And so it's just understanding that there might be some differences, most likely there will be differences. But if there's no information for them to even find out, then that just makes it harder.
So it's not just even navigating the tension, but actually communicating with okay, that's really helpful, thank you.
Jamie, Kristen, other than.
Kristen, why don't you go ahead?
Yeah, one thing that I see in here is reviewing the capacity of crisis stabilization facilities, and based on what we saw from the Stories project, I also want to suggest that we need to review what crisis stabilization and inpatient facilities should be like. What services should people be receiving when they're in those facilities? What should discharge planning look like? Because even if we have enough beds to put all of the people who need those services in them, it's not going to make a difference if those services aren't working for people and aren't resulting in them staying out of crisis once they're stabilized in those facilities.
Okay, so not just reviewing capacity, but what actually happens in this facilities, what can people expect and what should it be like? Thanks, Kristen. I'm gonna queue up for Tori, Chloe, and Louise. I'm gonna give you an advance warning. I really appreciate fresh eyes on this work that we've done here. And so I'm hoping you can think about in the next few minutes my answer to this question, which is, after looking at this, do you see any holes or gaps? And I promise you, we won't be insulted if you point out any holes or gaps, but I think having your fresh perspective on this is a real value to us. So why don't you noodle on that, and I'll come back to you in a few minutes to see if you have any thoughts on that. Claudia, can you say something? Yeah.
Yeah, I wonder if we really doing enough in terms of, we talk about a vision of being inclusive and a system that is inclusive to all different communities. But if you look at the story, today doesn't include anybody of a person of color coming from other countries, new immigrants, the experience of the system. And I know as being a provider, how much torture the system is, but there's still, I wonder if we need to lift their voices a little bit more. I wonder if we need to really look at, because we talk about, oh, do they have translation or the translation is available, but it's not that it is on the forefront all the time. It's almost like asking the question, and okay, I get the answer to understand, but we really honestly need to uplift the voices and look at the, we talk about accountability and it's really start putting that in the forefront, otherwise the underserved will continue underserved. It's just a very, and it sounds like I said that before, but I just want to let that again, we have the community.
I appreciate that, Claudia, and I do want to honor that that has been a key theme that you brought up many times. I also want to acknowledge that that ties very importantly to the comment that Puck made at the end of the presentation on the lived experiences story project, that there are some limitations in terms of who is reached with that, and that's a big place where we need to do some work, so I appreciate that. I'm kind of in the
I'm gonna sound like a broken record because I have been mentioning this since I joined CRIS. And that is the issue of law enforcement response. This is an issue that keeps getting brought up, and I just feel like we just keep kicking the can because we can't agree on a solution. And right now, despite what certain King County reports might say, there's a King County report that supposedly more Black people call 988 than white people. Well, nobody asked those people whether they still felt comfortable doing it.
911 or 988, I'm sorry.
Huh?
911 or
98. There was an article that was released by KUOW where it stated that more Black people in King County call 98, but there was never any follow-up question of whether or not they actually felt comfortable doing it. And as someone that works with people with lived experience daily, this is still a continuing issue where they do not feel safe calling 988. They won't call 988. If they live in rural communities, they are more likely to get a law enforcement response. And if we're going to decriminalize mental health, we need to work towards taking law enforcement out of the factor and making sure that everybody gets a therapeutic response to their crisis.
So, and I know this has been, maybe it's been a broken record, but I know this has been a really, really important thing to you, particularly we raised it a lot during our time together. And so in the report, you would like to see was really elevated as a place where we must come to some decisions.
Yeah.
Okay.
May I?
Yes, please jump in.
Yeah, I wrote, when I posted, the one I wrote is, people who don't feel safe with the potential of a law enforcement response. Be that because of how their community has been treated, be that because of their immigration status, be that any reason, still deserve crisis support? Like, that shouldn't be a question. And we're still asking like this is a question where it's like either you're comfortable with possibly having law enforcement response or you don't get crisis support. That doesn't work.
Thank you for that. Okay, let's see, a hand up from Natasha.
So a couple things I just wanted to say, and Michael and Kristen, you can check me, but we did have one story. What we mined from these stories is like Dr. Snowden, who guide us on this presentation. Thank you, Dr. Snowden. It's just the tip of the iceberg. We just gave lip service as we moved through the presentation. We did get a story that specifically said, if you don't speak the language or if you have an accent, you are not taken seriously and given the support you need. So that sort of echoes what Claudia, you said. And a gap that I feel that is not here is what we brought up in a presentation today. And over the past 3 years, I've been hearing it at the Lived Experience Subcommittee meetings, and I've talked to several people, and Puck brought it up. This space of where a person's agency lies versus where can the system step in to get them help. This is a very sticky issue, and everybody I've talked to, like, nobody wants to touch it. And I want to harken back to what David said during the IDDDD presentation at the start of today's meeting, is that when you have a problem, you should spend most of your time looking at the problem and understanding it in depth without thinking of the solution first. And I think this is an arena I would love to see the state delve deep into. Like, if we could have a conference where we could start this conversation between what happens if a person is not able to give permission for care versus families saying they need care. And I think if we as lived experience who might look at it from different perspectives can't have a conversation about this, we're never going to come up with guidelines or protocols that are really going to be helpful for either end. So it is my heartfelt request that the state maybe try to put maybe a conference together on like the issue of anosognosia versus personal agency. Thank you.
Gosh, that was very nicely articulated of the outcome we want, which is to find that right balance between individual agency and when you need to help someone who doesn't realize they need help. And I love your conference idea. I think there's probably a way we can note that that's a suggested tactic. I'm going to come back to our newest members, Tori and Blaze and Chloe, and feel free to decline if you didn't see anything, but if there's anything that you want to share with us that you saw as new members that you think might be helpful insight for us about what we might have missed.
Yeah, hi, this is Chloe. I think for me, a lot of it, just from what I've reviewed, comes down to a lack of services, not only for prevention, but for, aftercare after someone is hospitalized. In my work, we see a lot of people who are going through hospitals, jails, and then, they become true blood class members, which opens them up to some more services. But the comment that I left was talking about increasing community-based services, especially for the specialized populations, such as folks who have IDD, because we know that, a strictly just police response can have some pretty severe impacts on those folks. So yeah, I think a lot of it comes back to the services that people can access.
Thanks, Chloe. I think that nicely connects with the comment that Kasha made earlier about a space where we clearly need to continue doing work so that there's a there for people who call the crisis system. Sorry,
This might be in the weeds, but just something that is on my mind every day about when we start looking at the services, and we're doing some really good work in certain regions around what are the core services, like for crisis receiving facilities, for example, and I'm going to call out King County and the new Kirkland facility, that we really need to be benchmarking to what we know works. The Arizona system has a lot of things that work. We're now finally building some of that into our system. And so when I was thinking about like the oversight and performance piece of like, how do we monitor longer term? Is this working? We're going to need to have, I think, a little more standardization in a framework around core services, right? So that, and here's the social worker hat in me, is that if I'm directing someone to say, okay, here are your options. If we have so many of these crisis receivings, you have 23-hour recliners, it's great. We're adding more services in. Yes, this is good. But if there's not standardization among that, then it's going to be a really piecemeal system. And so I think back in my days of being a social worker and working with people, it would be really hard for me to try to figure out, so if I know exactly where to go, and here's your core services, here's what you can expect. And that's really helpful for people, because I think that's what's happening is they're cycling through the system. There's more, but not everybody's aware of what those services are. They're very different regionally. You will have regional differences. There's obviously going to be a difference between rural and more urban. But at the end of the day, I think we're going to have to get to a little more core standardization so that we really can have that oversight longer term.
And Alicia, am I right that nicely fits with what you were talking about earlier? Yeah. Thank you for jumping in there, Tori. Hershey.
I think going off of that too, when we think about someone to call a safe place to be or go and someone to come
do all three of those elements of the system have the same definition of crisis? Do they all have resources? And do they all think their role is the same? Or are you going to get something different if you call 988 versus go to a 23-hour CRC versus get an MRSS team to respond to your home? And I don't know that we have delved into that enough. That might be a place that we need to continue to do work, because I think some of those places see their role as de-escalation in some ways, but really connection, stabilization and connection to care. And others see their role really emphasizing de-escalation and de-emphasizing the connection to care. And we will really do ourselves a disservice if those three components of the crisis system, which we're seeing and speaking about as equal, don't actually work from the same playbook on how they're supposed to support people in crisis. And do they all have the same definition of crisis? Do you get something different if you're experiencing a suicidal crisis versus an aggressive crisis, or you're a person with IDD and crisis in those three different spaces?
Kashi, I think that was just so well articulated, and I'm glad we're recording this, because I feel like I want to transcribe that into the report as a way of characterizing one of the big issues that we've been wrestling with. So thanks so much. Blaze, what do you think? Do you want to jump in, or do you have any?
Oh, no, not at all, but I'll do it.
Okay.
Yeah, no, I absolutely don't want to. So I'm just listening, like, I'm just soaking it up. There's just a tremendous amount of information in here. And part of it is like I have to translate what everybody's saying because I speak a different language, because I speak police. So I'm trying to soak up what everybody else is saying. I see lots of concerns, lots of recognition of gaps and holes and needs. And I don't know what else has necessarily been done, but where are the recommendations for how do we fix, or how do we fill this gap? How do we fill this need? Like, there's a conversation kind of holistically about we need to talk more, we need to coordinate more, and we need more consistency. And I mean, I don't have the answer on how to get there necessarily. I mean, just some things that come to mind when there's a need for providers, right? And people need to come and do these jobs, right? And there's an overwhelming understanding that there's not enough people to come and do the job. And those that are getting their butts kicked. I mean, repeatedly, and then they're walking away. Well, welcome to law enforcement, welcome to education, welcome to, care, nursing. I mean, everybody's getting their clocks cleaned right now. But for this group in particular, I mean, maybe there's programs out there to, yeah, money is important, but, I mean, for a long time, teachers could get discounts on housing, law enforcement get discounts on housing, and that would lure them into certain communities. So that could bring people into communities that may not have certain resources that maybe you could pull them into just with that sort of idea. So, I'm just lots of need, and I don't know, where the other conversations have gone as far as suggestions for solutions.
So, Blaise, if I'm hearing correctly, it sounds like you're going around, you're looking at these recommendations, and you're saying, okay, there's some big things that this group wants to see solved, and what you're wondering is, what are the specifics about how each of these things might get solved?
Yeah.
Okay, and I'm actually just looking over at our wonderful Department of Health and Healthcare Authority folks, who are the principally the two agencies that are charged with at least leading on the how for things that are within state level responsibility. Tisha or Michelle, do you want to say anything about that, or did I say that right? Is there anything you want to add to that?
Yeah, sure.
Okay. And I also saw a hand up over here. Okay, welcome to you guys.
So I think one of the thoughts that I had actually when I was going back and looking at all of the recommendations was, and honestly, I didn't say this so far because it's a very different thought than what I've heard in the room so far. So I was a little bit shy to say it, but I'm gonna go out there and say it anyway. I was actually pretty proud of these recommendations and how many of them I think we started implementing. That is not to say that we should stop doing anything or more work doesn't have to be done. But one of the things that I did notice was like, oh, we're doing work there. Yep, we're starting to implement that. Yep, we got stuff going there. But it's hard to see all of the wheels of change that we're putting into place.
And honestly, there's like 100 things written on that list back there. And so can I stand up here and say intelligently or thoughtfully, like, oh yeah, this, boom, 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 this is all we're doing? I'm just like, oh yeah, we've got, I know we're doing something there. Yeah, I know we're doing something there. So I actually walked away and thought, wow, this past 3 years of these recommendations, I hope people walk away and see what an impact this is making. And it can be really hard, I think, to see that. And myself as someone who works in the agency probably needs to do a better job of celebrating some of the successes that we have had. So I guess the thought that I want to say is not in any way that we don't need to do more or that we've done enough, but that these recommendations have been helpful and we are attempting to implement them. And sometimes implementation just takes some time for things to be made.
Thanks for jumping in, Tisha. Oh, Michelle, you want to jump in?
I think Tisha covered it.
Okay, great. I'm gonna wait a second, Anna, and then
So now I have two things just to follow up with Tisha. As a non-public policy director, I meet with other non-policy directors from across the state. And we talk on a regular basis, and I have to say that Washington State is miles ahead among most other states, and that is because of all of y'all work. So I just wanted to add that in there, that we are ahead. Yeah, we still have a lot to do, but if you look at where we're at compared to other states, we're far ahead. So good job, everyone. And then second of all, going through all those, I found sticky notes for you regarding youth through the entire continuum of care.
Yeah.
There's a huge gap in youth services when it comes to crisis. Yes, we passed a wonderful regarding 23-hour youth services, but we still need them. We don't have enough mobile response. Do we have mobile response just for youth right now? Is that something that's established? We need more services for preventative care for youth. We need to acknowledge youth, and we need to have a system that's going to serve their needs.
first of all, thanks for sharing that insight from your conversations with NAMI reps from across the states. I think that's really meaningful to this group also to hear, what you're doing, so much impact. And I saw the same thing you did. Thanks for bringing that up. That clearly that's a big area. So I guess this is the.
Yeah, I just want to go back for a second on this idea of like, well, what do we do with the recommendations now? And I sit on a few different committees on behalf of the governor's office, and one of the things I would say is that there are a lot of reports out there and a lot of recommendations, and a lot of them just go, and even the ones that are very well done, oftentimes just sit. And so one of the things that I've seen that has been most effective is building the buy-in behind the recommendations through coalitions like this. And following through on the work, right? Continuing to do some of the work. One of the best examples that I sit on is the Children and Youth Behavioral Health Work Group. They have not only sort of a very impressive coalition of people who put the recommendations together, but they continued on that work throughout the legislative session, throughout, working with legislators, working with the governor's office, working with other policymakers. And so just to your question, I'm like, well, these recommendations are great, but now what? That's one of the things I would really encourage as people are looking at this is doing that work, the folks with lived experience coming to the legislature to the extent you can and having those conversations, reaching out to your local legislators. That's what I've seen as one of the most effective tools, is not only putting the recommendations together, but having that really community buy-in behind what the recommendations are to keep the work moving forward.
So we are tying this to the report, the final report. It sounds like if there's maybe some actionable things that we can all take away that we can do to keep moving this forward, even as this phase of CRIS kind of sunsets. That would be, in your experience, that would be a good way of keeping it sort of just being a report on the shelf.
Yeah, and I think that includes, that certainly includes engaging the executive branch, getting the state agencies involved in terms of like, how do you implement? That's one of the things that's usually a big piece of the puzzle is how do you resource this properly? How do you staff it? How do you stand it up? And like I said, it's just, like I said, in my experience, when you have that broad-based
coalition of people, community stakeholders, state government workers, legislators who know and understand the recommendations. And so one of the most effective ways I've seen in terms of improvement.
To Jane.
So ditto to what Amber said, but a point of reality, there's a lot of recommendations. And I think part of it is, I was super happy to hear that the report is gonna look at which recommendations that we've done over the years have had actions taken. And acknowledging that an action being taken might have impacted 10% of the issue, but there's still 90%. Having spent many years as a legislative staffer, my reaction to a report like this, when somebody would come and say, we think this is really important, would be sort of like, well, what do you think your priorities are? So be prepared to respond to a question like that if you get it. And then the other thing is we're hearing that the budget for next biennium is not looking good at all. We've had 3 years of really good revenue forecasts and a lot of federal funding coming into the state. And that's not happening. There's a couple of initiatives that are on the ballot that could really have a big impact on the state budget. So one question that will always come up is there any way we could use federal funding to help pay for these things? So just like think about it from those perspectives. Speaking as a veteran.
We always appreciate your wisdom from your travels. Anyone want anything or something? Okay, I'm gonna read this from Pasha. Everyone on Zoom can see it, but I'm gonna read it so folks in the room can see. In our lived experience subcommittee, we did say, in our lived experience subcommittee, we think the Hub Park is doing good work. Has least, sorry? 5 comments, and also that people are happy with mobile crisis teams. Also, my reading on updates from agencies makes me go, brava, especially the following. Dedicated youth teams in the state have expanded from 4 teams in 2022 to 14 teams currently, increasing coverage from 5 counties to 18 of 39 Washington counties. And HCA successfully obtained a state plan amendment that removes the former 14-day limit on in-home stabilization and allows up to 18 weeks of in-home stabilization in alignment with national best practices. That was effective last January. And those are in the newsletters. So if you haven't had a chance to look at the newsletters, which are also posted online, I think that will also help you track what has been done on many of these recommendations. But as Jane mentioned, it will also be synthesized in the draft report. Any concept? Anyone else have any final reflections on the recommendations? Any gaps you want to make sure we call out, or any other thoughts to give your report writers before we dive into that?
So, in keeping in mind what Jane said, I think one of the gaps that we're gonna still have is that gap for the highly complex patient situation, the person situation. And this is where we still don't have good answers for when law enforcement should or should not be involved, what that should look like. Crisis receiving centers will be great for a good number of people, but they won't be able to care for a highly complex patient that has, or person, I come from the hospital, sorry. So I think that gap's still there. What does that look like? What do we need to do? We're still gonna have, this still doesn't have recommendations that will really address that person that's stuck in the ER for days and weeks at a time. Who there's a lot of calls from the community, more 911 than 988. What are we gonna do? So we still have that to look at. And so I just want to make sure that we recognize that gap.
Thanks for listening, Darcy. Okay, I think we're gonna wrap up this discussion because I did promise that we'd leave some time. We didn't get to, because of our audio issues, we did not get to the update about what's next for engaging with lived experience. So I do want to spend a little time on that. I know it's very important to many of the folks in this room and on Zoom. And then we also have 2 people signed up for public comment today. They're both on Zoom. So I'm gonna hand it over. So first of all, I'm just gonna say what we're gonna do with all this. So we're gonna, first of all, carefully take down all of those sticky notes, and I'm gonna take those home and transcribe. Also, we have the Zoom whiteboard here. And Nicola and I are going to use all of that to help write the sections in the report that show your recommendations and also gaps that still need to be addressed. So that's what we're going to do with that. And our intent is that when you review this report next month, you will see your feedback today reflected. So that's what's happening with that. And now I'm going to ask Tisha and Michelle if you want to share updates. I know this committee's been interested in hearing about what's next for next for lived experience engagement. Was that something you feel to talk about? You're the county.
No, I am totally, I wasn't totally prepared to talk about that. I mean, I can talk about the fact, I can just give a general update. We have, we met with the lived experience committee to talk about the fact that kind of the evolution of the CRIS and how we're getting to the point where with the legislation that it's gotten to the point that it's evolving a little bit, especially with the transition of the healthcare authority taking over the facilitation of the ongoing CRIS meetings after beginning in January. One of the ideas that the members of the CRIS Lived Experience Subcommittee came up with, and it was a brilliant idea, would be willing to come back on a monthly basis until January to their subcommittee just to talk about how that transition is going. I was like, yeah, that's a good idea. So then also this was one of the updates that I didn't give earlier when we were doing agency updates that thank you for giving me the microphone again, because I wanted to bring this up, was just to make sure that everybody is aware. And I don't think we got an email sent out broadly through the CRIS news, the CRIS distribution list, just that what I just shared before, that starting in January, the facilitation of the CRIS meetings does transition from HMA over to the healthcare authority. And so they're probably gonna look different. What exactly they look like in the future, honestly, we're still working through those details. Don't have it quite figured out yet. It probably will also look a little bit different because right now there's been so much wonderful work done and focus on creating the recommendations. And those, as we've been talking about a lot today, those recommendations go into the report that's due in December. So once that's done, then what do these meetings kind of look like? Are they probably going to transition to more of a focus on how are we doing with actually implementing these recommendations? Kind of like what you brought up, like what's actually happening? We made all these great recommendations, what's actually going on? Also, I'm assuming that folks would like information on like, how are we coming with actually achieving all of the things that in legislation we've been told to achieve? So how are we doing with making the transition for kind of like getting to our future state that we mentioned in the policy recommendation of 90 our scale? How are we doing with building up technological solution? Kind of all of those types of things. What does it look like to make sure that as we build out a robust crisis system, that we still make sure that we gather feedback from people who are actually utilizing the system? So that was one of the updates that I wanted to be able to provide. More information than that, I'm not sure that I have.
Okay. I'll share a little bit about, maybe a little more detail about what we shared at the lived experience subcommittee. Like, we absolutely, as state agencies, have seen value in lived experience subcommittee and have a huge commitment to ongoing lived experience input into our work. It happens in a lot of different ways right now, and there's always room to do more. So I think when we think about it, Tisha and I, at a very high level, we don't have details figured out, but as we talk with our teams, we want a place where we can bring updates to lived experience, people with lived experience to get feedback, like, hey, we're thinking about this or that, or we're working on implementing how do we kind of get some guidance, get some input, help us stay grounded as we think about how we're implementing and doing work. And then we also are interested in continuing ongoing work for the type of qualitative research that kind of was done in the lived experiences subcommittee. We don't have the answers about what all those things look like or how we're doing it from the 3 call centers about the value in that lived experience space to kind of have both to be able to do that, to get information on where things are going well or not going well, so we can do more investigation, to get feedback into the decisions or implementation actions we need to take. And then also thinking about how do we understand how well the system's working and what we need to do. So one of the next things Tisha and I are doing is bringing our teams together to kind of talk about where our existing spaces we have. There's a lot of other spaces, especially where healthcare authority is convening, or some other state spaces where there is lived experience seats at tables or subcommittees. So we can look at where are those, what are they covering, where are the gaps, and what else maybe we want. And I think later this fall, we'll be able to bring some of that information back, both for lived experience and those ongoing meetings, like Tisha said, and to the committee. And I think this is an area that could have recommendations in the final report, is a level of what's the ongoing desire and want as far as types of lived experience engagement within the crisis system long term.
Thanks, Michelle and Tisha. Any questions for Michelle and Tisha on their updates? So it sounds like maybe a little more to come. Okay, I do have an update from Betsy too, so I'm hand it to her.
Thanks. And speaking of transition, I want to let you all know that I will be leaving HMA at the end of next week. In November, I will be Chief Strategy Officer at Community Health Plan of Washington. And just wanted to reassure everyone that that this project is on track. The continuity will be overseen by the Behavioral Health Institute and my incredible team. So that's, you won't be seeing me anymore, but just wanted to let you all know.
We will miss you terribly. Thank you, Betsy. So, Christine, can you put the slides back up? I think I might have a couple closing slides to go through before we move to public comment. Okay, so we have next slide. Oh, okay. I might call on Nicola, but Nicola, can you remind our CRIS committee members of when they can expect to see the report for their review so they can plan for that?
Thank you, Jamie. We can follow up to this meeting with a more specific timeline, but I think you can expect it at least 2 weeks in advance of your November meeting, but more toward the mid-October. So we're working to give you several weeks to review.
And one more request, I apologize, but I have dates just colliding in my head. Can you remind us of when our next CRIS meeting is in November?
It is November 14th, I believe, or 13th. Let me just get that right, Jamie. Yeah, November 15th. Yeah.
November 14th?
13th.
13th, November 13th. Okay, everybody. So our next one is November 13th. Our next and last one, we'll have more details coming soon for the upcoming CRIS. And as Nicola said, you'll have at least 2 weeks in advance of that meeting to review the report. So we'll give you a more firm date for when you can expect to see that, and you can plan that out. Also wanted to let you know that Dylan is going to be on family leave, and so won't be with us at our last meeting. All right, Dylan? Dylan is why we're expecting that first baby, so congratulations, Dylan. And any other updates from anyone like this? With that, then let's move into our public comment period. So we have 2 public comments today, Jean Ross and Jay Worley, and they're going to be participating via Zoom today. We do have a timer that Christine's going to run. So just a reminder to everyone that the CRIS committee is just going to be listening. Your job is to listen. We're just going to be not responding to comments today. And folks who are providing comments, Jean and Jay, if you have any written versions, please send them to our project mailbox, which I'm gonna ask Chloe to pop into the chat to everyone. And that will help us make sure that they go verbatim into the record. So what I'm gonna do is I'm gonna call Jean first. You'll have 2 minutes to make a comment. You'll see the timer running. Please turn your video camera on and start speaking when you're ready. And then after that, we'll go to Jay. So let's start with Jean.
It's actually, I need about another 2 minutes. Is it possible for Jay to go first?
Sure, Jay, are you ready to go? I can have you go first if you don't mind.
Yes. Thanks, Jay.
So Jay, go ahead and turn on your camera and start speaking when you're ready.
It should be on.
Yes, I see you. Perfect.
Hello, my name is Jay Worley. I am a lived experience advocate of IDG with homelessness, and I was a youth homeless. When it comes to family, I just wanted to primarily speak on that. Family isn't always family. Our natural resources aren't always the best, and sometimes they turn on you or reject you. And so we may want family to participate, but sometimes it's the worst thing possible for us. Sometimes it is damage and the trauma that happened to us. So it is something that needs to be considered greatly. If when you're returning a child to their family, if it is more of a danger, then a good thing. Second, I wanted to say thank you for all of the work. I've heard a lot of things that normally I feel like I need to bring up, but I don't feel like I need to today. There are a lot of us that are taught to mask and participate in society, but don't know how to. After a certain point, we can no longer continue to mask and we fall through the system. And those are the people that I see unable to get into permanent supportive housing, unable to get into systems and programs, and unable to deal with time placements when it comes to counseling, things like that. When we go to counseling, we look at the situation and we're like, okay, well, we're gonna have a counselor for 6 months and then we got to start the process all over again. By the time that they actually know us, we're gonna be exiting counseling. So there's no reason for us to continue to do it. There's no reason for us to enter into a short-term relationship to heal deep issues. And sometimes going to psychologists are just bad because of medication trauma, which is something that isn't talked a lot about, where people take medications and it causes them lifelong trauma and inability to deal with or interact with anybody who's requiring them to do so. There are other issues. I'll put it in writing. Thank you for your time.
Thank you, Jay. And if you, again, give written comments or written speaking notes, please do send those to the email box that Chloe put in the chat. Appreciate your time today. Jean, do you feel ready to go?
Yes, I'm just trying to get my camera on and my voice to cooperate due to allergies. Okay, let's see.
Your camera doesn't work.
It's saying that the video is not on.
Oh, there we go. We see you.
Oh, okay, very good. All right. So first of all, it has been really just amazing to hear all the work that this dedicated committee has put into working on the CRIS Committee. And I'm happy to see Senators Warnick and Dingra again. What I'm coming to this final meeting of the committee as both a parent of now a young adult with autism and as one of the founding members of the Washington State website, Washington State funded website, Behavioral Health 360. And I'm really impressed that there's going to be a focus both on continuing inclusion of learned experience and on prioritizing the recommendations, because I do have a sense of how long and how difficult it can be to implement the very best ideas. And one thing that I I want to call out is it is very important to make sure that the crisis options that are there are available to our youth and young adult with behavioral issues. When our son was having huge challenges, so many of the places that I called that were covered by insurance just said no, either because of the extremeness of the behavioral issues or because they did not serve youth with autism. I put probably 6 or 7 different things in my notes about things to consider. And I thought one of the most interesting one, and I'll highlight this one, is we had a situation where our son was really struggling, young adult. It happened to be in Snohomish County. The sheriff actually called me and told me what was happening and said, parent, mom, what is it that we're trying to accomplish today? That example of teaming was so impressive. And I know there are lots and lots of things that I included that probably many other people have included, but I thought that particular approach was both creative and resulted in an almost immediate de-escalation in our son's behavior, because he was hearing from me on the phone, plus the police officer, what things needed to happen to calm down the situation. My main point before all my insights that I've gained, many hard won, was that every single intervention must include de-escalation. Anytime somebody with IDD is having behavior that, having behavior that is unacceptable, they're already extremely upset and have cognitive challenges to contend with as well. Thank you.
Jean, thank you so much for your time today. And again, if you have written speaking notes that you can share with us, please do send it to that email box that Chloe put in the chat. I think that, is there anyone else, Christine, that signed up to make public comment today? No? Okay. Well, folks, I know it's been a long day for you, but hopefully you feel like it's been a fruitful one. It's been really good to see all of you. Thank you for being here in person, everyone who's able to make it in person. And thank you for spending the day with us on Zoom, folks who are on Zoom. And we'll look forward to talking with you in November. We'll be giving you some more details soon. But in the meantime, everyone stay healthy, be well, and safe travels home wherever you're going. Take care.
Thank you.
Oh, yes. Right. Everybody, when we have our new voucher, please come to my phone.
No, that's not appreciated. I am just.